work on that. My name's Travis Leach. I'm the president here at St. Alphonsus Regional Medical Center. I've been on St. Alphonsus about 14 years. Had a little break, but I've been back just short of a year. And delighted to be in this room today. This event is pretty special to me. I used to be the director of medical staff services a long time ago here at the hospital and helped out with the original creation of the spring symposium back in, we figured about 2011 is when we started. So we cobbled this all together. We've been going strong for nearly 15 years now. So first, I just want to say thank you to the medical staff office and everybody included behind the scenes and then in the room here today. It is a lot of effort to get all the CMEs approved and accredited and all of the kind of things you have to do to make sure that we have a successful day today, finding all the speakers and so forth. So thank you to all them here at the front, making it all happen today. So appreciate that. Also want to welcome everybody that is online. We have people from all across the health system, from Baker, Boise and beyond. And so thank you again for joining us. So we feel like this is a really important offering to our broader Treasure Valley and beyond community. So again, hope you all have a wonderful day today. There's another special and really important thing that we want to do today, and that is I'm going to invite Dr. Lisa Nelson, who's right in front of me, to come on up. We want to honor Dr. Nirmal Sharan, who was very instrumental in the early days of this symposium. We just got to participate in a celebration of life. Dr. Paula Corval is here today, too, in the back. He, a great friend of mine, very special human, and we want to spend some time honoring him this morning. And Lisa will be our MC today and take us through everything. So anyway, just want to again wish you all a wonderful Friday. Have a great time learning today. And thank you so much for being here and participating. Have a great day. Lisa.
Thanks, Travis. It is really, truly my honor to bring this remembrance of Dr. Nirmal Sharan to you today. Really special part of St. Alphonsus's history and the community's medical history. He was the former medical director of graduate medical education at St. Alphonsus, and he passed away in December 2025. He worked at St. Alphonsus from, got feedback here, sorry. He worked at St. Alphonsus from 2010 to 2019, and then continued in an adjunct capacity. In his position as the GME medical director, he was responsible for bringing WAMI medical students to St. Alphonsus for some of their clinical rotations, and that's now a very strong and thriving relationship. He was instrumental in setting up the early efforts to formalize the GME office and consolidating medical clerkships. He and his wife, Dr. Carvalho, have been longstanding members of the St. Alphonsus medical staff, providing important clinical services to our patients and our community. Dr. Sharan was also instrumental in the administration of the John Butler Lung Foundation in Boise, which hosted a medical conference for doctors annually. Dr. Sharan organized this conference for 21 years. He will be remembered by many for his kindness, his talent, and definitely his fun personality. We're blessed that he has been a part of our lives here at St. Alphonsus. So we're moving on, Callie. All right, let me get this slideshow going. Okay, thanks. So in order to make sure that we can get you guys the CME that you've come for today, We just want to share that many of our presenters today have no disclosures, and for the few faculty that have, they have been resolved. That we are able to offer CME today through the IPCE through Trinity Health, and we thank Trinity for our ability to do that. This program has been approved for interprofessional continuing education. With that out of the way, a few other housekeeping things. There are restrooms for those of you in the room out the back door and to your left. You'll see there's a hallway there. There's restrooms out there, and feel free to stand up, stretch. We're going to be sitting for a long time today. We won't think it's weird if you do, and I might make you guys do that later today anyway. And please feel free to get more coffee, water, whatever you need. So I am really pleased to be introducing Dr. Wesley Pidcock, who is one of our pulmonary critical care physicians here at St. Alphonsus Regional Medical Center, where he has practiced since 2020, and that was probably an interesting time to start as a critical care doctor here. Originally from a small town in Idaho, Dr. Pidcock grew up with a deep appreciation for the outdoors, and this was an early influence that later shaped his commitment to environmental and community health. Today, he works to advance sustainability initiatives within the hospital system and to raise awareness of the growing connections between climate change and human health. And I am really looking forward to hearing his story. Thank you for being here today, Dr. Pidcock.
All right, well, thank you for having me here today. I was asked to talk about how I became involved in climate and health and kind of go through my story from where I started to where I am now. So like I said, I grew up in a small town in southeast Idaho called Inkom, which if anybody's ever heard of it, it's about 800 people and it's about 12 miles south of Pocatello. My family had a big 1,000-acre ranch out there. And as a result of growing up in Idaho, I kind of grew up doing all the things that we all love about Idaho, that being hunting, skiing, fishing, backpacking, hiking. And I think for most of us, and myself included, the reason that I continue to live here is really primarily because of these activities. And I think that's why most of us come here. And I'll say that what I want to walk through is like how my appreciation for those activities has kind of like got me to this point. And I will say that if you were to ask me this question when I was asked me a question about climate change when I was in high school or even in undergrad, I would have told you that I didn't really believe in it, didn't really think it was, thought it was probably a hoax, is something I would have said. I don't really like admitting that, but it's kind of the truth of where I started. What did change for me though, is that as I was doing those activities that I mentioned in that picture before, I noticed that things were slowly changing. My family skis a lot and we still ski a lot. And I remember talking to my grandparents who would talk about how when they would always ski on Thanksgiving. And I remember when I was growing up, I was never able to actually ski on Thanksgiving. Came close a couple of times, but never actually able to do it. But when I was, in high school and undergrad, I was always pretty able to consistently ski around Christmas. And I've noticed now that even that's getting hard to do. They might have like a patch of snow that's open, but it's not real skiing like it used to be, where there would be like actual, like the good chunk of the mountain that's open. And you can see, when you actually start looking at the data, this kind of shows why that is. And what this shows is that on the x-axis here, it breaks down by decade. And then on the y-axis, it shows average annual snowfall. And this is taken from the Boise Airport Station. And if you look by decade, if you can kind of see the trend in there is like a definite significant decrease in the amount of snow that we're getting. And we're actually down about 38% from where we were before. That last column in the 2020s too doesn't include the last 2 years. So that doesn't include this last winter, which was, as we all know, pretty terrible. And so it was, that was really when I kind of started to notice it, was when people would talk about that. And it was always just kind of this thing that was said in passing, be like, yeah, the winters aren't the way they used to be. But there was no talk about like why that might be. I also noticed that, growing up on a ranch, I moved a lot of irrigation pipe. And I would notice that, as I got, in my early 20s, that a lot of times that we would be kind of stretched for water, and that we would have to kind of maybe skip some days that we'd water some fields just because there wasn't the amount of water there, primarily due to also because it was getting really, really hot. And this graph shows kind of that feature as well too. That if you look, this goes all the way back into the 1890s, and you can see the average temperature here in Boise was around 49.5 degrees Celsius, or Fahrenheit, I should say. That's the average temperature for the entire year. And you can see that trend to where now in the 2020s, our average temperature up here is around 55.4 degrees Fahrenheit. And I should also say that does not include the last 3 years here, which are the hottest 3 years on record, globally, I should say. And then that bottom graph there shows the number of days at which we were experiencing here in the Treasure Valley that are over 100 degrees. And in the 1890s, we were getting like 1 or 2, and now we're all the way up to 10. So things really changed for me, though, when I married a climate scientist. And I should really say that's probably the main reason that I'm here, is because a lot of this stuff that I had kind of like noticed, and I will say that like my opinions on this subject was like gradually changing to where I was coming on board with it. Obviously, that if that wasn't the case, I don't know if the marriage would have worked. But as a result of being married to a climate scientist, we have some pretty interesting talks over dinner, and some of these are going over like some of these graphs such as these. So I fully admit these graphs are 100% stolen from my wife and all these figures, and then my ability to interpret them are 100% stolen from what she told me to say and how to interpret them. So, but the way that works is if you look at this graph, it's really fascinating. And I think you don't have to be a climate scientist to understand that, you know, there's something significant happening here. But the easiest way to look at that, if you look at the period from 1860 to 1900, or sorry, I should say 1850 to 1900, what they did is that they took what the average temperature is in that time period, and that's considered to be our baseline. And then every year after that, they looked at what the global temperature anomaly is, so that anomaly above that baseline temperature. So why do they pick that time period? That's a time period when we really started getting into the Industrial Revolution. So we started emitting a lot of greenhouse warming gases. And you can see that in the 1920s, you start seeing those global anomalies kick up, those global temperature anomalies kick up. And then it really starts revving up in the 1940s and 1960s. That's relevant because, you know, it's World War II and Vietnam. And then you can also see that our economy and the way that we live our lives really started to change as well too, and our emissions dramatically increased up, and as a result, these global temperature phenomenons really increased quite a bit as well too, to where now you can see we're on this exponential curve. It's increasing, and it's, you know, some of these numbers I think are just like, if you haven't heard them before, it might really surprise you. But in the last 11 years, those are the warmest years that have been recorded in our 176 years that we've been recording temperature. And in the last 3 years, those are the hottest records, or hottest years that we've ever had globally. Now that might not be here within Boise itself; those are global temperatures. But again, it just highlights that how severe this problem is becoming. Another way to look at it is with this video. See if we can get it to work. So this looks at kind of the same thing, but it's comparing the global temperature phenomena from a baseline from the 1950s to the 1980s. And what this shows is that the blue marks are when the temperature is below what that average is. Anything that's white shows that when the temperature is kind of right at the average. And anything that's red shows that the temperature is above that. And so you can see when we were in the 1880s and 1920s, we had a lot more blue. That's because we're comparing to that 30-year average from the 1950s and 1980s. Now we're getting more of the average there because we're in that time period. But you'll see that once we start getting in past the 80s, that we start seeing a lot more red, or a lot more temperatures that are higher than normal, especially over some of the land masses. And if you pay attention to the poles as well too, that those are really starting to get high. And then it really starts revving up in the late teens and early 2000s and 20s, I should say. So kind of the same thing that I was showing you in the graph, but the visual, I think, always really drives it home for me. The other thing that really changed for me that got me wanting to get involved with this is that we had a daughter in 2023, and this was her first summer. I think a lot of us remember that. This was 2024, and during that time period, we had a lot of AQI values above 200. For those of you that aren't familiar with what an AQI is, that's a measurement of the amount of pollutants and particulates that are in the environment that we breathe. I use this a lot in my pulmonary clinic to guide some of my patients on when to know that it's safe to be outside. If you're in one of those vulnerable groups, that being anybody with like cardiopulmonary disease or a child, it's really not safe or advised to go outside when the AQI is above 100. And if you're in, even if you don't have one of those diseases, you're not one of those sensitive groups, when it gets above 150, that's when it becomes unsafe to be outside. And this period here was like some of the worst smoke that Idaho had seen in 25 years. And that smoke, as sure as all of us remember, really lingered around here for 2 months. And it was really during that time period, and also of like learning about all this stuff and seeing some of those graphs, that I really just kind of felt like a strong desire to want to do something, especially when I look at this figure. And this figure is, I joke with my wife that this is one that I really like, and I also hate it, and it's the one that keeps me up at night, because once you understand it, I think it really just shows what the future may look like. And so to walk through some of this, what this shows, those different colored bars are what the global temperatures are compared to that pre-industrial phase there, or that when the Industrial Revolution began from 1850 to 1900. And it shows those anomalies of those changes above that baseline. And you can see that if you're someone like my parents, who was born in like the late 1960s or early 1960s, you can see that when they were born, they didn't really see that big of a change in their temperature fluctuation. But now when they're in their 70s, we're really kind of starting to see some of those impacts with those climate anomalies and significant disasters that we've seen. And if you look at someone like me that was born in the 80s, we're just starting to get into it. And what this model shows is what it may look like someday when I'm 70. And what this graph here on the right shows is different scenarios depending on what we do going forward. So this very low scenario would be if we were to somehow stop emitting greenhouse gases completely. And then it all the way up to the very high shows that if we continue as what they call business as usual, meaning that there's not really anything that's being done. And then all these other ones are some combination of that. And you can also see here that like someone like my daughter, who was born in 2023, what she's experiencing now and what she will experience when she's 70 years old. And what this shows is that you start seeing that when she's 70, you'll start seeing global temperature phenomenons above 4 degrees. And right now we're experiencing about 1.4. Another way to think about this is that, you know, my daughter has experienced every year, she's experienced the hottest summer that she's ever experienced, but she will also in her lifetime likely never experience a summer that's cooler than that. So just a way to kind of think about how this is changing. The other thing that I like to ask about this is, does anybody have any idea what pathway we're currently on in these scenarios? Yeah. We're 100% on the very high pathway, and this slide's a couple years old, and there's actually some models now that show that we're above this, where we're currently going. So that's the thing that really motivated me to want to do something about this, is because it's about, you know, for those of us that have kids, when you see this kind of stuff, you know, you worry about that, like maybe they won't necessarily be able to do some of the things that I grew up loving to do in this state, because it's just not going to be the same. And then I also, you know, obviously because I was thinking about this stuff a lot, I started noticing it in my clinical practice as well too. Whether that be that I see somebody in the ICU that comes in for heat stroke because their air conditioner went out in their trailer and they come in with a core temperature of 105, 106 degrees, or my inbox is blowing up when the air quality is bad because of everybody's got a COPD or asthma exacerbation, or talking to some of my patients that haven't been able to go outside for 2 months and have had to create like a clean room in their house. And that's really kind of where they've had to hunker down until all this stuff changes. And so it's, you know, I think all of us are seeing this, but unless you start, you know, really paying attention to this stuff and learn about some of this stuff, you don't realize some of these connections. And the more that I've done this, I kind of see it everywhere now. I've also been able to work it into some of my clinic visits as well too, where I'll talk about the AQI, and then also, if I have enough time during that visit, kind of explain where some of this stuff is coming from. And also, I've had mixed reviews. Some patients love it, and some patients roll their eyes when I talk about it. But anyway, I'd say for the most part, it's been well received. But when all this stuff was building and seeing all these different changes and stuff like that, I definitely felt like a strong desire to want to try to do something. And so initially what my plan had been was to organize just a ground round lecture to just kind of go over the basics of climate change. And my motivation for that was really just kind of like, you know, I felt like we, you know, at that time, I didn't feel like we were really doing anything about it. And I kind of wanted to just at least get people talking about it. And so to start with that, oh, and I should say before I get in there, and one of the reasons that I felt like that was important to bring it to in the healthcare space is that a lot of people don't realize that when you look at the greenhouse gas emissions and where they come from. I think most people know that they come from transportation, so our cars, air travels. Big, huge chunk of it comes from the way that we generate power. Another chunk comes from industry, and then about 10% comes from agriculture. But there's 8.5% that comes from healthcare and the way that we buy things, the type of gases that we use for various procedures. But healthcare, as most of you aware, isn't highly wasteful, and so we have a huge emissions footprint. And if you look at the number of people that are contributing to transportation and electricity generation, that is a much bigger pool than the people that are contributing to the healthcare emissions. And so really for all of us, the spot that we can make the biggest impact is really going to be in how we practice in healthcare. And so what I did to start with this is I reached out to this organization called the Idaho Clinicians for Climate and Health. They're primarily based here right in Boise. They are a statewide organization, and it's a collection of healthcare professionals across the state who organize regular lectures where they bring in people from all across the country to talk about climate and health. They also have multiple events throughout the year where they're trying to educate the public, as well as initiate some policies to try to help make some movement in this. I pointed out because if you're looking for a way to get involved, this is by far the easiest way to do it. And they're always looking for people to join. And it's also just an easy way to get plugged in to start getting some lectures to learn about this stuff. So anyways, one of the things that's interesting about these folks, though, is that a lot of them were based out of St. Luke's, and they were very excited about doing a lecture. But their goal had actually been to do a symposium or like a day-long event. And they had been trying to organize that at St. Luke's for years, but had been unable to do it. And so when I went to them, they said, well, how about we do it at St. Alice? And I was like, well, I have no idea if we'll be able to do that, but I can ask. And so I literally just went to Dave McFadden. I said, I want to do a symposium. And he said, fine, here's $6,000 for food and bringing in some speakers. And then I met with the med staff people, went through the process of doing the CME, which I will echo what Travis said. It's a nightmare if you've never done it before. And don't take it completely changed my opinion of CME whenever I claim the credits because of how hard it is. It took me a month to get the application through. But a lot of that was the hard part for me was just not knowing how to do any of that kind of stuff. And I was surprised how much support there was for it. I literally just asked and was plugged into the right people and got everything organized, including all the way up from having this flyer made for this symposium. I just sent an email for what I wanted it to look like, and someone sent that back to me. And so once we picked our spot for it, we then were able to find speakers from across the country who came in to talk about that. And what's interesting is that because we live in a state like Idaho who doesn't talk about this stuff a lot of speakers from around the country were very excited to come here just because they don't ever get a chance to interact with this audience. And that's something I found from other things when I go to other places about this stuff, like other conferences or events and stuff. There's a lot of people that want to come and talk to me just because of that reason. And I will admit that sometimes when I go to these scenes, I feel a little bit insecure just because we're not doing nearly the amount that these other places are doing. But it's kind of been the opposite. Everybody wants to get us involved so much that it's been a very welcoming experience. But at any rate, this symposium, we did it last May, and it was received very well. We had about 130 people show up for it. And including the mayor who came in and talked about some of the stuff that the city of Boise is doing to reduce their emissions as well. And then the interesting thing that happened after we did that is, I kind of planted the flag that I was into this kind of stuff. And then everywhere I would go, someone would stop me in the hallway and say, I want to do something about this. So I was surprised about the amount of people that were actually interested in this, but just didn't really know what steps to take. And one of them was Dr. Amaji, who is one of the OB doctors here in Boise. And she instituted a program where she got rid of all the plastic speculums just in one OB clinic. And if you go through and you do the math on this, and that's about reducing the amount of 692 kilograms of CO2 per year. Another way to say that at least resonates with me a little bit more is that's the amount of admissions that it would take that a car would produce if it drove 1,730 miles. So that's just 4,000 speculums in one clinic, right? So, but there's a lot of stuff that goes into that, like how do you process the speculums and all that stuff. So it took us a couple months to get through it, but now it's something that they're doing over there pretty easily. And so we're hoping to try to expand this to other clinics, and hopefully maybe eventually the ED as well too. There's also other people here that are doing stuff with our power generation. Sarah Spadell and Derek Miller have gone through and done things such as simple as like turning off ORs that are not being used, because there's a lot of, with the HVAC system, of turning over the air in the OR and keeping it at a certain temperature. A lot of them would just run 24 hours a day. And so it was literally something as simple as turning those ORs off. And they were able to save enough energy savings to power 55 homes. They also saved the institution so far about $50,000. And again, we're just getting started with this. And this is just as simple as turning off the OR. One of the other things we're looking at is turning off like screensavers on computers that nobody's using, or turning off like automatic lights, that kind of stuff. And the interesting thing, that's the thing that I found that's so interesting about this. Not only is it good in terms of like the amount of emissions that we're saving, but all this other stuff tends to save us money as well too. So it's really, there's net benefits for it. And then the last project that we've been working on is getting rid of the anesthetic gas, or certain types of anesthetic gases here. So one of them is we were going to try to get rid of this gas called desflurane, which is an older anesthetic gas. But what's interesting about it is that one molecule of that gas is the equivalent of 25,000 CO2 molecules, which is the main CO2 gas. And, you know, we were getting all, you know, putting all our ducks in a line to kind of go to administration to talk about getting rid of this gas. And it turns out Trinity had already decided to do it. And so they eliminated it from all their formularies. I point that out just to show that, like, this is something that is that even the people at like the higher levels of our organization are paying attention to and are trying to do. And then one of the other things that we're currently doing is trying to get rid of our centrally piped nitric oxide. The reason for that is that nitric oxide, it has one molecule that is equivalent to about 273 CO2 molecules. So it's got a high global warming potential. It also hangs around in the atmosphere for 110 years almost. And the way that we currently do that is that we pipe it through all the central systems so that you can plug into the wall and use nitric oxide. Problem with that is that they leak like crazy. And so we don't, and there's not a ton of places that are really using it, but we still buy a lot of it just because we're replacing the amount that leaks out centrally. So one of the things that we're doing is isolating the places where we use it and trying to put gas cylinders there instead of using the centrally piped stuff, as a way to both lower our emissions and save the amount of money that we're spending on nitric oxide. So that's ongoing, and that's being led by Dr. Wilson right now. Oh, I'm sorry. Can you hear me a little bit better? Apologize. Yeah. And then one of the things that I've been doing, because, you know, after I did this, was trying to decide, like, what is the next thing that I should do. And I received this email from the University of Columbia about a sustainability healthcare leadership institute. And so it's a year-long program that I enrolled in last fall, and all ran by the University of Columbia. And it went to a 3-day retreat where you meet with all these leaders in this field. And now they have us meet on a monthly basis, and with either lecturers are coming in there, or also talking about like a various project that we're working on. And my project that I'm working on is hoping to launch this hospital sustainability work group. And the goal of this is to, you know, I found that everybody is doing a little bit here and there. But I think if we could really bring all of us together to where we had like, and kind of share some of our resources and experience, that we may be able to start even making some more headway on that. So stay tuned. You'll be maybe seeing an email about that coming out soon. And some of the things that I would like to do going forward, again, these are big goals for me, is trying to green the OR. I hate the styrofoam in the cafeteria, so I really like to try to get rid of that. Keep working to get rid of the energy efficiency, and then also kind of start looking at some of our supply chains and where we can both save money and lower our emissions there as well too. We're also planning on doing another symposium in September. It's funny now, since we did ours last year here at St. Alphonsus, St. Luke's wants to do one now. And so they're doing one in September where they'll be hosting it. And so the goal is that eventually we'll kind of like take turns with it every year. This year, it's going to be on September 2nd, so put that in your calendar and try to attend if you can. The breakdown for the symposium is going to be broken into 3 different sessions. The first one being heat, followed by smoke and water. And there'll be a series of panelists on there that'll kind of go over the science behind it, the health impacts, and then some of the solutions, both nationally, globally, as well as locally as well too. So I'm really excited about it. I hope it's something that you could attend. I've found it to be very helpful. In summary, though, what I would take away from what I learned about this is, climate change is definitely affecting our home and the populations that we care for. I have been surprised by the amount of enthusiasm that's around for tackling this problem, including from administration. Anything that I've asked for, they've been able to work out a solution for me, so they've been fantastic with that. And I really do feel like that there are simple solutions that we can do here locally that will make a real impact, both in reducing our emissions and lowering and in saving our healthcare system some money. If you wanted to get involved, because that was something that I felt when I first started doing this, is not really knowing where to start. I think the easiest thing to do is to join that Idaho Clinicians for Climate and Health. Lots of opportunities for that. I'll say again to attend the symposium that we're having on the 2nd. And then I'll also say that, I'm pretty new to this. I've only been doing this for a year and a half. So if at any point you have an idea of something that you would like to do or something you'd love to go through, reach out to me. You can send me an email, or if you see me in the hallway, you can ask me, because I would love to start working on whatever project you have. I don't know if we can necessarily, if I'll know how to figure it out, but I know we can figure out who to ask to get the problem solved. So with that, I will take some questions if there's any.
So if you have questions, raise your hand. I'll come over just so the folks online can hear your question.
Hello, Nancy Coyce. Education, small people. It seems like that's where the future is. How do we get that message? And what's been your experience with trying to get that message in our education system so that people who can do something in the future can participate?
I will say that I haven't necessarily educated any small people. My daughter's 2.5 and she gets it all the time. That's about the only person that I know that gets it, right? But what I'll say that from what I know about this, and I'm far from an expert in it, is that if you look at the younger generations, they know this is a problem, and it's consistent in the polling across it. This is something that they're worried about. So I don't necessarily think that it's a problem with them not being aware that it's a problem, not going to affect their solution. What I take away from when I've gone to just a couple of these conferences and I've listened to presentations on this, is that there's a huge mental health crisis with younger folks about this problem, and a lot of it centers around that it can feel overwhelming, and there's also just a lack of power on their part. None of them they're all so young, they're not really in a position to where they can do anything about it yet. And so what I would say is that I think it's incumbent upon us that are a little bit older and maybe are in position of power is to start doing something about it and being a model for them, and then eventually handing the reins over to them. So I don't know if that answers your question, but that's.
Here, I'm going to give you back the microphone.
Thank you. Thank you for your wonderful presentation and inspiring. I guess what I'm wondering is it hopeless to think that we can have an influence with educational materials in the classroom, or are we so highly regulated that we can't bring this information to young people? Other than just hearing it from their parents and friends, is there no, and I know maybe you can't answer that question, but my feeling is are our classrooms so regulated that we can't bring this message in a formal way to young people?
Well, I'd have to say I don't know. I think this is a total guess. I would think it would kind of depend on where you are. I would say in an area like this, I'd be very surprised if kids in their primary education are getting taught about this. I think if you went to other states, maybe where this is more on the agenda, they probably are doing that. But I don't have anything to back that up. It's just a guess. Yeah.
Thank you for an excellent talk. I'm Layla Soliman. I'm a psychiatrist. So what you said about mental health really resonated with me. I'm curious if you'd be willing to share your most rewarding moment with this and maybe your most challenging and how you kept going.
Ooh, that's a good question.
Sorry, maybe that's too.
Yeah, no, that's a good question. I would say the most rewarding moment for me was probably when we were able to get the symposium to go through and it went well. You know, that was exciting, and the enthusiasm around other people to just feel like we were finally talking about it. But there's lots of times where there's like low points in it because this is a, you know, overwhelming problem, right? You know, that requires way more than like one individual to do it and like one city to do it. It's the whole world that has to do something, right? So there's certainly times where sometimes I just have to take a break from it and not read about it and write, you know, especially now because it kind of feels like we're reversing things and not necessarily really doing any of the stuff about it, right? So sometimes I just don't read the news or take a break from it, right? So yeah.
When you talk about greening the OR, there are some advantages over plastic for metal. Having been intubated by metal and broke both my teeth on both sides and gotten St. Luke's to change their policy because they were allowing anesthesiologists to do that, to go to softer type things, which of course is plastic. Myself, I don't have any problems between metal and plastic speculums because I've used both. But I see situations where if you try to green the OR by changing how you intubate, we're going to have some complications since I've suffered them myself
Sure.
at both hospitals, both here and that was even with posterior teeth protection, because we don't protect the posterior teeth when we intubate. So I've lost a molar on both sides. This one I haven't taken out yet because it's been broken for 13 years,
Right.
But I'm going to be forced to take it out now for some other reason medically. So essentially, how are you going to do this? I mean, is there some way of making plastics or metals into softer things so that they don't damage things when you're intubating and going over to something that's in between?
Yes. And so I think, I don't mean to have a cop out here, but I'm not a surgeon and I'm not in the OR a lot, right? So like the inner workings of the OR, like I'm not as familiar with, right? And so a lot of this, like my plan to attack that would be to start this committee, get some surgeons on there who I've already identified that are interested in this, and then figure out ways that we can go through there. And I'm not talking about that we get rid of all the plastic immediately. It's just going to be picking like one or two things that we can work on slowly, and then over time make those changes. Like a good example from other hospitals I've seen, this is not necessarily related to like the OR, but there's all this stuff that we do, for example, with contact precautions for hospitals like MRSA is like the key one that we know that doesn't really work all that well. And those gowns that we're using, right, have like a huge CO2 impact in terms of like the amount that it takes to produce them and to dispose of them. And so if you can do simple things just as going through and like educating your hospital, changing some of those policies, you can eliminate the amount of waste that comes out of there and make small impacts like that. But to your point, I don't really know yet. And there's a whole long list of things on way to go through this stuff. But that's kind of what I'm doing when I go through this, is trying to like, all right, how do we do this? What's one problem we can tackle? And then as we tackle that problem, a lot of times other solutions come up for me.
First, thank you for your focus on changeable things in your sphere, particularly the styrofoam issue. Thanks for tackling that. I think that should go away. Second, how do you feel that weather modification actually impacts all of the statistics and the data that you shared with us earlier?
Like weather modification, you're talking about like cloud seeding and stuff like that? Is that what you mean?
Yes.
So what I read about that is that those are where that could potentially be useful would be like for a brief period of time in like a local period, right? But that none of those things are going to be anything that's going to make a huge impact over the long run, just because to do them at scale requires oftentimes like puts out more emissions than it actually benefits from. And a lot of it is just to like, you know, to seed the clouds, to, you know, put some rain down in, or to protect from like high heat for a brief period of time. But none of that stuff, when you actually do like what the amount of CO2 that you're using versus the amount you're saving, there's actually a net benefit to it.
My question was actually on the negative side. So how is that actually impacting the negative trend that we're seeing at the moment? for the last couple of decades.
Can you ask me your question one way? I'm sorry, I don't know if I understand what you're asking me. I apologize.
So putting metals up in the atmosphere, right, has to have some sort of a negative impact on the world in which we live. Have you learned anything in your studies that actually show how that negatively impacts the weather trend that we're currently seeing?
No, I'm sorry, I don't know that. I don't know about when they talk about like cloud seeding, like putting like the metals up in there, so or what that does. So I'm sorry, I don't know the answer to that.
We'll have to chat with your wife.
Yeah, right? Yeah, I think she's listening right now, so I'm sure I'll hear about it tonight when I get home.
All right, I see don't see any more raised hands here. So thank you, Dr. Pidcock. That was really interesting. It makes
Yeah, thank you.
this feel less overwhelming.
Yeah.
Right, that there's a place to start now. So
Exactly.
thank you so much.
Yep. Thank you.
We're going to just briefly make a quick mic adjustment before we introduce the next speaker. All right, so as I was choking on my coffee, looking at some of those graphs, I thought it's really, really good that I have two emergency medicine physicians sitting right next to me. So I am really pleased to introduce Dr. Dan Houseman, who is an emergency medicine physician at St. Alphonsus. After graduating medical school from the University of Pennsylvania in 2008, he completed his residency in emergency medicine at Los Angeles County Harbor UCLA Medical Center, where he served as chief resident. He currently serves on the St. Alphonsus, multi-specialty peer review committee and is an instructor in the Vituity Difficult Airway course. His professional interests focus on clinical decision-making and procedural education. Dr. Houseman has worked at St. Alphonsus since 2020 and lives in Boise with his wife and 2 children. Welcome, Dr. Houseman. Thanks for being here.
Thank you, Dr. Nelson. Can everyone hear me okay? Great. Please feel free to get some more coffee. I know that's super important. As Dr. Nelson said, my name is Dan Houseman. I'm one of the ER physicians here at St. Alphonsus. I'm really excited to be here today to talk to you all about how we can improve outcomes in out-of-hospital cardiac arrest. Whether you work in a hospital or an outpatient setting or just happen to be out in public when a medical emergency occurs, my hope is that you can come away from this lecture with a few pearls that can help you provide the best care possible to the most critical patients. I have no disclosures. So we'll talk about 3 things today. The first is high-quality CPR and early defibrillation and its impact on out-of-hospital cardiac arrest survival. We'll go over a few updates from the 2025 AHA guidelines on adult cardiac arrest. And finally, we'll talk about some new innovations in cardiac arrest care and how they might change what we do to manage these patients in the future. I want to start with a story though, and this story happened over 30 years ago, but I think there's still valuable lessons that we can learn from today. The story involves this man, Hank Gathers. In 1989, Hank Gathers was one of the best collegiate basketball players in the country. He was a 6'7" power forward for Loyola Marymount University in Los Angeles. He's one of only 3 players to lead the NCAA in both scoring and rebounds in a single season. He's seen here with his friend and teammate Bo Kimball. Hank and Bo grew up together in North Philadelphia and then continued their playing careers together at LMU. They were the cornerstones of a fast-paced LMU offense that would often put up 120 or 130 points per game. Early in Hank's senior season, he had a syncopal episode during a game. He was taken out of that game, and after extensive medical testing, he was diagnosed with an idiopathic cardiomyopathy, but he was prescribed a beta blocker and he was cleared to play the rest of his senior season. On March 4th, 1990, at a home game in Los Angeles, Hank scored on a picture-perfect alley-oop and then retreated back to midcourt on defense. He suddenly collapsed to the ground. He's able to regain consciousness and sits up briefly with a stunned look on his face before he becomes unresponsive again and collapses. The team's medical staff and Hank's own family, who was in attendance that day, were at his side immediately as a stunned crowd watches in silence. What follows is about 5 minutes of Hank laying there unresponsive with no intervention being done. He's then taken off the court into the locker room where CPR is started. There's a defibrillator there. He gets shocked, and an EMS crew arrives and takes him to a local hospital. Despite maximal efforts and a prolonged resuscitation, they could not get Rosk, and Hank Gathers died that day. It was a devastating loss for Hank's family, for his team, for his school, and the entire basketball community. One of the tragic footnotes to this story is that there was a defibrillator at Hank's side immediately after he went down, but it wasn't used in that 5 minutes that he lay on the court until he was moved into the locker room. We'll never know if that would have made a difference or not. Hank's impact on his teammates and his family was profound. When faced with the choice of canceling the rest of the season or playing on, his teammates chose to play in his honor. They made a deep run in the NCAA tournament that year. They lost in the Elite Eight to UNLV, who went on to win the national championship. In one of the more poignant moments in sports history, you can see Hank's friend and teammate, Bo Kimball here, who's right-handed, shooting his free throws for the rest of the season with his left hand, just as Hank had done. But Hank's legacy went beyond basketball. His death and other similar incidents in young athletes prompted changes to how schools and professional athletic teams prepare for and rehearse for such an emergency. So let's fast forward to present day. Sorry about the format there. Each year in this country, about 350,000 patients suffer an out-of-hospital cardiac arrest. 10% of them survive. In 1990, the year of Hank Gather's death, that number was about 8%. Despite 36 years of resuscitation science and evolving guidelines, we haven't moved the needle that much on out-of-hospital cardiac arrest survival. Importantly, only 8% survive with a good neurologic outcome. It remains a challenging diagnosis to treat and a major public health concern. This is a challenging disease process because it requires a high level of care and coordination between the public, EMS, emergency medicine, ICU and cardiology, and rehabilitation services. In the 1990s, the AHA introduced this concept of a chain of survival to highlight the importance of each step in a patient's cardiac arrest care. This has been refined over the years and now includes 6 links: recognition and emergency activation, high-quality CPR and defibrillation, advanced resuscitation and post-cardiac arrest care, and finally, recovery and survivorship. Any gap or delay in any of these areas is going to negatively impact a patient's outcome. The chain is only as strong as its weakest link. I want to mention that the last link, recovery and survivorship, was added in 2020 and highlights the fact that patients who survive cardiac arrest face both short-term and long-term challenges. About 50% of patients who survive cardiac arrest meet criteria for post-intensive care syndrome 3 months after discharge. Many suffer from PTSD, anxiety, and depression. Patients and their families and their caregivers require comprehensive support as they recover. I think it's worthwhile to talk about the basics of out-of-hospital cardiac arrest care. High-quality CPR and early defibrillation of shockable rhythms are the 2 most important interventions we can do for patients. Without these, any other intervention will not matter. If there's one slide I want you to remember from today, it's this one. Bystander CPR doubles out-of-hospital cardiac arrest survival. CPR maintains perfusion of the vital organs, and it can preserve a shockable rhythm. Unfortunately, as a society, we're not that great at doing this. Only about 40% of patients with out-of-hospital cardiac arrest get bystander CPR. Not all CPR is equal too. For CPR to be effective, it has to be done correctly. You can see in this image here, the patient's on a firm surface. The rescuer has his dominant hand on the lower part of the patient's sternum, fingers interlaced, knees are at the level of the torso, arms are outstretched. Depth of compressions is 5 to 6 centimeters with complete recoil of the chest. And importantly, these rescuers are alternating every 2 minutes. It doesn't matter how fit you are, good CPR is tiring. And there's studies that show that CPR quality degrades after about 2 minutes. Rate of compressions is going to be 100 to 120 beats per minute. The classic Staying Alive, 104 beats per minute, but there's entire playlists on Spotify or Apple Music that have hundreds of songs if you like something different. My 10-year-old daughter thought it was critically important that you know that Golden from K-pop Demon Hunters clocks in right at 120 beats per minute. What about AEDs? So AEDs first became commercially available in the 1980s. Over the years, the cost and size of these devices has decreased dramatically. Here are 3 of the most popular AEDs in this country. And I have a short video here featuring the Zoll AED Plus. This is the same defibrillator that's in the hallway outside this conference room. And I don't have audio, I'll just kind of comment as we go. So one rescuer calls 911 and retrieves the AED while the other starts CPR. The device is powered on, opened up. At this point, there will be voice prompts instructing the rescuers on the next step. Many AEDs are going to have a kit like this that has gloves and shears to remove a shirt or a bra to expose the patient's chest. After this, the pads are going to get taken out of the packaging. Ideally, we'll be doing CPR during this part. The pads have an adhesive backing that gets removed. As soon as those are placed on the patient's chest, the machine will automatically interpret the patient's rhythm to see if it's shockable or not. So the anterior pad goes on, followed by the lateral pad. At this point, the machine's going to analyze the rhythm, instruct everyone to stay clear while it analyzes. It detects VFib, shock advised, press shock button, shock delivered, CPR resumes. Despite improvements in AED technology and increased access, only about 12% of out-of-hospital cardiac arrests have an AED applied. This is unfortunate because defibrillation of a shockable rhythm is time sensitive. For every minute delay in a patient with out-of-hospital cardiac arrest with a shockable rhythm, the chance of survival decreases by about 6%. So we know that CPR and early defibrillation improve outcomes. We also know that there's widespread disparities in out-of-hospital cardiac arrest care and outcomes. Women and persons of color are much less likely to get both CPR and AEDs, both in public and in private residences. And an out-of-hospital cardiac arrest in a rural area has a 50% lower chance of survival than a metropolitan area. I'm curious, does anyone have any thoughts on where the highest likelihood of survival in a public location would be for out-of-hospital cardiac arrest? Any thoughts? It's a casino, bank, so certain public venues. I'll give you a hint. It's not that far from here. I bet most of you have been there. Airport. Which airport? That's a great guess, but no, unfortunately. So it's right here. It's Seattle-Tacoma International Airport. So in many ways, airports are the perfect scenario to stack the odds in a patient's favor. There's defibrillators everywhere. Seattle-Tacoma has 170 defibrillators throughout their terminals. There's security cameras that can see a patient go down. There's trained first responders that are able to start initial resuscitation measures. And definitive care with an ER, ICU, and cardiology services, often only a short ambulance ride away. There was a 16-year study that looked at all cardiac arrests at Seattle-Tacoma, and the results were pretty incredible. 78% of those patients got bystander CPR. 55%, more than half, had an AED placed. 44% of those patients survived to hospital discharge. This is 4 times the national average. So we can't expect to have those results like Seattle everywhere, but there's certainly things that we can do as a society that are going to improve CPR and AED use. There was a recent survey that found that about 65% of adults in this country have had some CPR training in their lives, but only a small fraction of them have maintained that certification. There's data now that suggests that children as young as 12 can be taught effective CPR and defibrillator use, and most states in this country do have laws that require some level of CPR training for high school graduation. Community education has become an important focus for the American Heart Association in an effort to relieve some of those disparities that I mentioned earlier. And there's literature that suggests that targeted training in underserved areas can improve CPR, AED use, and survival. So I want to switch gears here now and get a little more technical and go over some of the current guideline updates from the American Heart Association. Now, if you look at the entirety of the guidelines, there's over 700 recommendations, so I can't do all of them, but I want to leave you with 7 pearls I think are relevant to the adult patient with out-of-hospital cardiac arrest. The first is for BLS. So basic life support now has 2 separate algorithms. There's one for trained healthcare providers and another for laypersons. The trained healthcare provider one is similar to what we all learned when we did our CPR certification. We check a patient for responsiveness, check for pulses. If there's no pulse, we begin CPR and rescue breaths, 30 compressions for every 2 rescue breaths. The layperson algorithm, though, is much simpler. It's 3 steps. We still check a patient for responsiveness. If they're unresponsive and have abnormal respirations, we activate our emergency response system and begin immediate CPR, apply an AED as soon as one becomes available. Importantly, there's no pulse checks and there's no rescue breaths. It's hands-only CPR. The inclusion of naloxone is another major change for 2025. Opiate overdoses have quadrupled in this country in the last 20 years. They're a significant cause of out-of-hospital cardiac arrest, particularly in young patients. And Narcan is in both the trained healthcare provider and the layperson algorithm, as Narcan's been available over the counter since 2023. Importantly, both algorithms say that if a patient's unresponsive, we should start CPR first before administering Narcan, as it's unlikely to work if a patient's in active cardiac arrest without CPR ongoing. What about mechanical CPR devices like the Lucas device seen here? The current recommendation from the American Heart Association is that the routine use of these devices is not recommended for adult cardiac arrest. The reasoning for this is that there has been some pre-hospital data from the last 10 to 20 years that showed that patients who received mechanical CPR had either equivalent or worse outcomes than those getting manual CPR, especially if this delayed CPR or defibrillation. This recommendation was met with some criticism in the EMS and emergency medicine community. While an ER often will have appropriate staff to rotate compressors frequently and maintain a high level of CPR quality, this does pull staff away from managing other patients in the department who also might be critically ill. With appropriate trained staff, these devices can be placed quickly, though, and should not delay CPR or defibrillation, and we still use them quite often in the emergency room. I want to talk a little bit here about refractory ventricular arrhythmias, and this is a challenging clinical scenario where a patient remains in VFib or pulseless VTAC despite multiple defibrillations and antiarrhythmic medications. In a pre-hospital setting, an anterolateral pad placement is often used because it's quicker to apply. A vector change is a new strategy where we can move those pads to an anteroposterior location, and a dual sequential defibrillation is when we do both techniques. We use 2 defibrillators, 4 pads, 1 anterolateral, 1 anteroposterior. We deliver sequential shocks a few milliseconds apart, with the idea being that the first shock may prime the myocardium to be more susceptible to the second shock, and the overall current to the heart is going to be greater. There was a lot of excitement with these strategies a couple of years ago with a publication in the New England Journal that showed improved survival and neuro outcomes for patients who receive vector change or dual sequential defibrillation. However, based on the limited amount of evidence, the AHA does not recommend these for routine use now, but states that they could be considered. What about medications? So when it comes to medications in cardiac arrest, there's a bit of an elephant in the room, and its name is epinephrine. Epinephrine has sort of been the cornerstone for cardiac arrest care for a long time. It improves return of spontaneous circulation. It improves survival, but unfortunately, it's never been shown to improve a neurologic outcome. And the AHA recognizes this, but states that it's not justified to withhold a medication that improves survival when there's no way during the arrest itself to predict who will have a good neuro outcome or not. It's still a class 1 recommendation, 1 milligram every 3 to 5 minutes for patients as soon as possible in PEA and asystole, and for shockable rhythms after 2 to 3 failed shocks. Other medications that have changed, so no longer recommended for routine use, include calcium, sodium bicarb, and magnesium, though there are certain scenarios when we absolutely will use those medications. So let's say you run the perfect code, you get return of spontaneous circulation, and everyone does a high five. This is actually when our work really begins. The care that we deliver immediately after a cardiac arrest is just as important as what we do during the code. And I wanted to talk about 4 areas that have some recent updates. And that includes blood pressure, temperature management, cath lab activation, and imaging. So regarding blood pressure, the American Heart Association says that we should target a mean arterial pressure of at least 65 millimeters mercury post-ROSC. There are studies that have looked at higher or lower blood pressure targets that have not shown any benefit. Temperature control. So when I was in medical school, there was all this excitement over therapeutic hypothermia, and you probably remember this. It was on the front page of the New York Times and multiple magazines. There were studies in the early 2000s that showed if we cooled comatose patients to 32 to 34 degrees Celsius after cardiac arrest, that they have improved outcomes. But there's since been subsequent research that shows we probably don't need to do that for a lot of patients. One thing that's become very clear, though, is fever prevention is critical. Patients who have an elevated temperature after cardiac arrest do worse. And so they now recommend this deliberate strategy with a range between 32 to 37.5 degrees Celsius as acceptable in patients that are unresponsive after cardiac arrest. What about cath lab activation? So the AHA says we should get an ECG as soon as it's feasible. For patients post-ROSC, there's been a narrowing of indications in the last few years for which patients require cath lab activation and PCI, but there's still a class 1 recommendation for patients with a STEMI to go immediately to the cath lab as soon as feasible. And finally, imaging. So imaging is an important component of post-cardiac arrest care. The recommendation now is for consideration of a head-to-pelvis CT after return of spontaneous circulation in patients who are stable enough to go to the CT scanner. This has 2 advantages. It can identify the potential cause of the arrest itself. It can also identify complications from the resuscitation, things like rib, sternal fractures, and rarely intra-abdominal injuries. So one more thing, I know this talk has been on out-of-hospital cardiac arrest, but there was an important update to the management of adult patients with choking that I think is worthwhile mentioning. Historically, the recommendation has always been to perform the Heimlich maneuver or abdominal thrust for adults with choking. But the new recommendation is that in conscious adults with severe foreign body airway obstruction, we do actually 5 back blows, alternating with 5 abdominal thrusts repeatedly until the object's expelled or the patient becomes unresponsive. There's data now that suggests that that has a higher chance of clearing the foreign body and is also less likely to result in injury. This is what we've been doing in children and infants for years, so it provides some nice continuity across all ages in managing this emergency. So now we've talked about some current guidelines. I want to take a look to the future and talk about some new innovations and technologies in cardiac arrest care and how it might change what we do. So the first one is eCPR. eCPR is the rapid deployment of veno-arterial ECMO, so cardiopulmonary bypass for patients with active CPR and still in cardiac arrest. The idea is to maintain tissue perfusion and oxygenation while we simultaneously address a reversible cause. This is already being done in some centers. There was a lot of excitement over this technology a couple years ago when there was a small single center study at the University of Minnesota that looked at patients in cardiac arrest who were randomized to receive either standard ACLS measures or they were taken directly to the cath lab where they were cannulated, placed on ECMO, and had PCI, had a cardiac cath. The trial was actually stopped early because of superiority in the eCPR group. 43% of those patients survive compared to 7% in the standard care group. Subsequent trials, though, have not demonstrated such a large benefit. And looking at these other research studies and meta-analyses, it's become clear that the two things are critically important, and that's patient selection and center experience. Ideal candidates for this are going to be younger, with a witnessed arrest, immediate CPR, short low flow times, and ideally a shockable rhythm. Centers that perform ECMO more frequently and have a shorter cannulation time have been shown to have better outcomes as well. For now, the AHA says that it's reasonable for select patients within an appropriately trained and equipped system. Another area I want to talk about is this concept of resuscitative transesophageal echocardiogram. We will routinely use an ultrasound during cardiac arrest to get a look at the heart, but this is a transthoracic ultrasound, so you take chest. It can give you a lot of useful information on potential reversible causes of the arrest, but it presents some logistical challenges. It can be difficult to get a good view of the heart while CPR is ongoing. And if we stop to do it during a pulse check, it can lead to unnecessary delays in CPR. So some centers will actually insert a transesophageal echo probe, which can give you crystal clear views of the heart in real time without stopping CPR. And it makes it much easier to diagnose and potentially treat reversible causes, things like pericardial tamponade, a dissection, or a pulmonary embolism. It has other advantages too. It can give us a real-time assessment of CPR quality. In the video on the left, a patient was in cardiac arrest and looked to be getting really high quality CPR, but the TE probe showed that the star here, which is the left ventricle, wasn't getting squeezed very well. By moving the hand positioning slightly and getting additional images, you can see in the middle that there's much more effective compression of the left ventricle and therefore hopefully better perfusion of the vital organs during the arrest. There's another cool advantage of this, and in the final video here, the patient appeared to be in asystole, so a flat line on the monitor. But with the TE probe, they saw that the patient was actually in a very fine ventricular fibrillation. They were successfully cardioverted with that. There's no data yet to suggest that this improves outcomes in cardiac arrest, but I think it's a promising technology to look for in the future. What about AEDs? As I mentioned earlier, only about 12% of out-of-hospital cardiac arrests have an AED applied. And in the future, AEDs are going to be smaller, cheaper, more accessible, and easier to use. There's already an app that you can get on your phone right now called PulsePoint that can give you the location of the nearest AED in the event of an emergency. I don't know if you can see down here, but it'll even tell you where it's located in the building and give you a small picture of it, of where it's located. There's a company now called Avive that has FDA approval for a direct-to-consumer AED designed for home use. And I don't have any personal experience using this, but I've seen some of their promotional videos. I think it looks pretty promising. It's incredibly easy to use. There's not just voice prompts, but actually a video on the screen that shows high-quality CPR at the appropriate rate. There's actually training paddles that you can use to practice at home without any risk of accidental electrical discharge. It can pinpoint your location to EMS services, and there's even a mode where you can be notified if there's a nearby emergency in hopes that a good Samaritan could take it out of their home, go into public, and place it on a patient before EMS arrives. There's one other cool story I want to share with you. This was from 5 years ago in Sweden. An elderly gentleman was out shoveling snow when he had a cardiac arrest. He collapsed, and a bystander walking by contacted their version of 911 and started CPR. Instead of waiting 10 or 15 minutes or longer for an ambulance to arrive, within 3 minutes, a drone carrying an AED landed at the patient's side. It was placed on the patient. He was successfully defibrillated and discharged from the hospital a few days later. So as I said, out-of-hospital cardiac arrest is much less likely to survive in a rural area, and it largely has to do with transport times and response times. So thinking outside the box and coming up with new and creative ways to get this technology in patients' hands is critically important. Finally, I want to talk a little bit about how artificial intelligence and machine learning may change how we provide cardiac arrest care in the future. And I think, fortunately, our jobs are safe for now. We're not going to get replaced by robots in the near future, but there are some exciting areas that are worth mentioning. The first is wearables. An Apple Watch is already pretty good at detecting AFib. And there's some proof of concept research now that's looking at its ability to detect a loss of pulse or a ventricular arrhythmia and automatically alerting 911. The majority of arrests in this country are unwitnessed. This could effectively turn an unwitnessed arrest into a witnessed arrest and shorten that response time and the early interventions that matter. Another area is prediction. There are large language models that are being developed that can integrate dozens of patient variables, things like vital signs and cardiac history, QT interval, that could give you some idea of which patients are at higher risk for an out-of-hospital cardiac arrest. And also AI and machine learning might change how we deliver CPR and analyze rhythms. There are models being developed that give you an assessment of CPR quality, not just based on rate and depth, but actually can use real-time physiologic variables, things like end-tidal CO2 and an arterial line waveform to give you assessment of your CPR quality. And there are some models that can actually remove the artifact from ongoing CPR and interpret the rhythm while CPR is ongoing, which would eliminate the need for a pulse check to see if someone's still in a shockable rhythm. Now, these technologies, they're still in their very early stages and they need to be thoroughly studied and make sure that they're effective. But I think with how fast this technology is developing, I suspect that how we run a code in 5 to 10 years from now will look a lot different than what we do today. So in summary, the future of out-of-hospital cardiac arrest care is promising, not just with new technologies and innovations, but also with thinking about new and creative ways to do the basics of cardiac arrest care. We reviewed a few of the 2025 AHA guidelines. And finally, I'll say it again, high quality CPR, early defibrillation are the most important interventions we can offer patients. To highlight this, I want to share one more story, and I'm sure a lot of you remember it. So on a Monday night football game 3 years ago, Damar Hamlin from the Buffalo Bills made a hard tackle on a Cincinnati Bengals wide receiver. Damar was later diagnosed with commotio cordis, where a sudden impact to the chest can precipitate ventricular fibrillation. He falls to the ground unresponsive. What followed was basically a masterclass in out-of-hospital cardiac arrest resuscitation. The Bills training staff and physicians who had repeatedly trained for such a scenario were at his side in less than a minute. You can see them checking a femoral pulse on Damar right there. He didn't have a pulse, so CPR was started. An AED was applied right on the field. Damar was shocked in front of 65,000 people in the stadium. They didn't wait till he got into the ambulance or to the hospital. They did it right then and there. Damar went to the University of Cincinnati Medical Center. He got outstanding care in the ER, in the ICU, and from the cardiology service. He was extubated the next day. He was discharged neurologically intact a few days later. He played in the Bills season opener 8 months later. Importantly, Damar Hamlin has used this experience to become an advocate for CPR and AED education and hopes that others will be inspired by his story to learn these critical skills and possibly be able to save a life. So that's all I have. I want to thank a few of my partners and colleagues who gave me some feedback and advice on this talk. And I really want to mention and recognize the men and women of our local EMS agencies, Ada County paramedics, Canyon County paramedics. They do an outstanding job providing emergency care to our community every single day. Here are some references. I thank you so much for your time and attention. I hope this was helpful. I'll take any questions.
Was fascinating. Thank you. Any questions? Oh, I see hands. I see hands. I'm coming around here.
Is there a role for mouth-to-mouth resuscitation for near drownings, drug overdoses in infants?
Yes, there is still a role for mouth-to-mouth and rescue breaths. The recommendation from the American Heart Association is that those who are trained to do so should if they're willing and able. That being said, though, CPR, any CPR, high quality CPR is better than no CPR at all. But there's still a role for, especially for things like drownings, for pediatric arrests. Rescue breaths are critically important because a child arrest is much more likely to be respiratory in origin than a primary cardiac origin. So the recommendation from the AHA is that if you are willing and able to do rescue breaths, you should do so. But high quality hands-only CPR is better than no CPR at all.
Hey, Dan Meltzer, first of all, terrific talk. Thank you. Really well organized and super informative. 2 questions. Any advances that maybe you didn't cover in terms of the pre-hospital setting? Curious what's happening there, since that's obviously they bear the brunt of it. And then back to ECMO, I know it is being performed actually in community hospitals. Curious, rate limiting steps locally and or what local or regional centers are performing it with some regularity.
Yeah, thank you, Dan. That was a great question. So a couple things for EMS. Some other updates have focused on intravenous access versus intraosseous access. The recommendation now is that we should still try to get an IV as soon as possible. But if we can't get anything, an IO is still an acceptable alternative. There's been some focus on airway management in the EMS literature, and it's largely dependent on operator experience and chance of first pass success. So a patient who's in cardiac arrest that can be intubated quickly by a pre-hospital team can be. But there are certain scenarios where it might make sense to bag a patient or insert a supraglottic device such as an iGel or an LMA. But in centers that can do intubation quickly with a high first pass success rate, that's still appropriate. The second question regarding ECMO. So we do have an ECMO program here. I know upstairs they do VV ECMO, they do VA ECMO. To my knowledge, there hasn't been a case of eCPR done here yet, but in talking to some of the heart failure cardiologists, if we had someone in the ER that had that perfect scenario, a young person, witnessed arrest, shockable rhythm, high quality CPR, I think I would make that phone call to my cardiology colleagues to see if we could do it. Yeah, you're absolutely right. It's being done in some communities, but the experience and the cannulation time are what really matters. So we'll see how it plays out. It's obviously a very intensive in terms of resources and cost, and there are some ethical concerns about who we do it for. But I still think for the right patient at the right place, it's absolutely indicated.
Yeah, excellent presentation. Early on, you said there's about 350,000 out of hospital cardiac arrests with 10% survival and 8% with neurologic intact. Is that 8% of the 10% or 8% of the 350,000?
8% total. So good neuro outcomes in 8% of total patients with out of hospital cardiac arrest. Those that do survive are more likely to have that good neuro outcome. And that's looking at something called a cerebral performance category, which is either normal or mild disabilities. Yeah, I was surprised by that data too. I would think that it would be lower, but that's the data that there's something called a CURES registry that looks at all cardiac arrests in the United States, and that's data right from them. Yeah.
Thank you very much. I am old school. So if we now don't do breaths, when there's no pulse, start chest compressions and do them till the AED gets on. And then if the AED says shock, and then how many more compressions do you do before you do the AED again? So
the AEDs will typically prompt you with the voice prompts to continue CPR until it's appropriate to do the next pulse check.
Got it.
And to be clear, so if for trained healthcare providers who have the experience and are able to do this, we should still do respirations. But for lay persons, or if it was a scenario where it wasn't safe or you're worried about disease transmission, it's definitely better to do hands-only CPR.
That is really helpful to know.
And there are little, you can buy these small masks that are really effective at essentially an N95 that you can place over someone's mouth to deliver rescue breaths if you're ever in that scenario.
Thank you so much.
Thanks.
Oh, other questions, here we go.
This is kind of random. So for out of hospital AED use, any tips if you've got someone with a really hairy chest and you don't have a razor? Because you can't keep your hand on the pad, right?
Yeah, and I don't, yeah, it's a good question. So they should still be able to stick. There's been some research that has said you might be able to actually use the first AED as a essentially a waxing of the chest, but I don't know if all AEDs are going to have enough pads to do that. They should still stick. It might not be as good. There is this idea that you can do something called manual augmentation, which essentially means pushing on the chest, which we do that in patients with higher BMIs to get better conduction. But you would want to do that with some electrically neutral substance like a rolled towel or a shirt or something like that.
This is just more of a comment. Great presentation. My name is Faith Boyd. I'm one of the faith community nurses that volunteers here with St. Al's. We do teach friends and families CPR throughout the valley multiple times a month. And when Hamel did go down, we actually had an increase in requests for CPR. So, and thanks to St. Al's, we have grants for that. And then we've also provided AEDs for many churches around the valley.
That's awesome. Thank you so much. That's great.
So I have a question. You know, my father had an out of hospital cardiac arrest. He survived, but unfortunately was one of those 92% with a poor outcome. From your experience here in the community, what's the best thing we could do to help people survive that, you know, have a better outcome? Is it the efforts that you are making in the faith community? You know, if you could say, hey, gosh, we could do one or two things, what would that be?
I think it's, increased community education, like already going on right now. I think having, classes that are free or low cost for the community and having an interest in that is critically important. Just taking a CPR class 20 years ago probably isn't enough. There's good literature that says that our skills degrade over time in emergency medicine, and CPR and AED use is certainly no exception to that. So having a low cost or a free class even where people can just do a refresher and just get hands on the mannequin, feel what it feels like to do good CPR, feel how tiring it is. And then figure out in the heat of the moment, you should rely on your muscle memory to put an AED on. So it just works that much faster.
Dr. Houseman, thank you. That was really informative. I was following your advice and got more coffee, so I may have misheard, but did you say at one point that women are much less likely to receive CPR? And if so, is there anything being done to help ameliorate that?
Yes, so women are less likely to receive CPR and AED use both in a private residence and in public, which I thought was kind of surprising. And I think some of that probably has to do with modesty. And you can see in that video, the chest is completely exposed. They rip everything off. And so I think increased awareness that we still need to expose the chest and get the pads on. This is a life-threatening situation. And I don't think it's an area for modesty, to be honest, when you're dealing with someone's life.
Hi, my one successful out of hospital CPR was in fact on a bridge, which got the paramedics into trouble getting there. But I was lucky that one of the RTs recognized me trying to do CPR on the side of the road, and they had an airway and they had oxygen. And so we started all that. And then the firemen had just been fitted with, this was a while ago, with defibrillation. Okay. And so they came in and we intubated the patient, could not get an IV in him. And the question is, you're talking about intramuscular epi if you can't get an IV. And I put it down the tube because I was more successful getting him intubated because I had this RT person and the paramedics and doing it that way. Is that still acceptable? I mean, he was in VFib. We intubated him. He didn't come around. He was still in VFib. I gave him the epi down the ET tube, and then we defibrillated him again, and he came around. And he had a complete neurological good outcome. He came into my office 5 weeks later and said, thank you, after he had his bypass for his coronary artery disease. Yeah. But I witnessed that one. I mean, I actually did a precordial thump because, I witnessed it. I was there and just got him off to the side, had his wife call the paramedics on the yellow phones, and then, did that. But is that still acceptable? Would it have been better to do the IM?
No, that's a great story. Thanks for sharing that. And you did everything right. You brought up a couple interesting points. The first was the idea of intramuscular epi. And so IV access obviously is going to be our first line. It's going to get drugs into the central circulation faster. Intraosseous is kind of the go-to now. So there's these little drills that will put a small device into either the humerus or the proximal tibia. And while we still want to get IV access if we can, we shouldn't delay administration of those meds, and IO is an acceptable alternative. You brought up a good point about endotracheal medications. Those have actually been removed from the algorithm. So you did the right thing at the time. But now, yeah, we're no longer administering things like epinephrine within the endotracheal tube. An IV or IO strategy would be much preferred. Oh, yeah, they'll do it. Yeah, 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 yeah.
Well, thank you. That was, again, great talk so far. We are a little bit ahead of schedule, and because we have folks joining us online, we are going to have a little bit longer of a break, but I thought it might be fun, at least for those of us in the room, to get to know each other a little bit better. I don't know if we're able to show the room at all, Callie, for the folks online, but I have some questions for you guys. So I'll just ask you to raise your hands. They're not invasive questions. Hopefully they're one that you guys will find acceptable. So I'm going to ask first, how many of you work at St. Alphonsus Boise? If you could raise your hand. So I don't know, maybe a tenth of the room here. St. Alphonsus Nampa? Oh, about the same. Well, you raise your hand. Our ER doctors everywhere. Let's see, St. Alphonsus, Ontario. Anyone come down from Ontario? Yes, yay. And how about Baker City? We'll have to work on that. We'll have to make sure to talk to Dave McFadden to give everyone in Baker the day off so they can come down. It's a drive. And then how many folks are joining us from the community today? Excellent, excellent, about a third. Thank you for coming. How many of us here in the room are physicians? So maybe about half-ish. How many are advanced practice practitioners? Maybe a 5%, something like that. And then folks who practice in other areas of healthcare. Awesome, thank you for being here. All right, here come the really important questions. Peanut butter. Raise your hand if you're a crunchy person. Crunchy peanut butter, creamy peanut butter. All right, crunchy people, we're gonna have to have a chat at the break. All right, you've made yourself a sandwich for lunch. Do you cut it, how many people would cut it sort of triangular from corner to corner? Okay, we have a few, all right, and then how about straight across? All right, the straight across, and how many don't care? All right, few people don't care. All right, this may be controversial. I know it is in my household when my mother comes to visit. How many of you put the toilet paper on the holder with the toilet paper hanging over? All right, over, and then how about under? Oh, the overs have it. I win. I'll tell my mother she's wrong. And she may be online listening right now, so Mom, there you go. All right, last question. We are, I think, in playoffs for basketball. So how many of you are basketball people? Like you're a basketball person, that's what you're gonna watch, okay. Football people? Baseball people? Really don't care. All right, everybody, thanks for coming. We're gonna break. It's gonna be a little bit of a long break so we can get back on schedule till 9:45 or so. So please get up, stretch, chat with your neighbors. There's lots of coffee and snacks back there, so please help yourselves. Thanks to our great speakers this morning. We'll see you in a little bit, 9:45. My apologies. Oh, no. Yeah, I know, it's like a step out.
It's pretty good. It's not too bad. And it looks good on here.
It's great. So it's like, seconds. I just don't know how to play. Yeah. Is this? Yeah, that's true. Yeah, I expect that. No, I. She's the one. Yeah. So I'm just letting you know. It is.
We would try.
That's true. Which is great. Yeah. No action. So. Yeah. Yeah. She's been out.
Try to convince them.
Any
Right. Dr. Reese Nelson's. She was a college professor and taught physiology. Very cool. And she took care of me as well. So she has a above your average level of knowledge.
Yeah, I think so. Oh, Dr. Weather.
Yes. Hi, everyone. I think it's just about 9:45 or so. So I'll have folks take their seats and we will get started again. I am very pleased to introduce Dr. Matthew Nelson, no relation, but this is a true story. My brother-in-law's name is Matthew Nelson. So one time I sent Matthew Nelson a text saying, hey, I talked to your mom and you're not working today. So why don't you come on over for dinner at 5:30? And I got a response, great, can I bring my wife and kids? True story. Dr. Nelson is the medical director of the Preventive Cardiac Lifestyle Clinic at St. Alphonsus Medical Center. He completed his medical education at the University of Iowa, Wake Forest University, and the Mayo Clinic in Scottsdale. After his cardiology fellowship, he underwent advanced interventional echocardiography training and is currently part of the structural valve team at St. Alphonsus. He loves to tell his patients an avocado a day keeps the cardiologist away. Thank you and welcome, Dr. Nelson.
Thank you. I've heard an expert comes from out of town and has slides, and I come from Eagle. And I have slides. So how many of you went to the cardiology symposium? Okay, some of this is going to sound familiar, but it's good to hear it twice. It's really good. But I've added a little bit to it. So I wanted to talk about calcium scoring, and then I want to talk about the lifestyle, what I say in like 5 to 10 minutes to my patients about their lifestyle. So here's a patient presentation. This is a 54-year-old guy who comes in with an NSTEMI, and he gets a PCI to the LAD. His blood pressure is good. He doesn't smoke. He doesn't have diabetes. He doesn't have hypertension or high cholesterol. His hemoglobin A1C is 5.5. His cholesterol is not too bad at all. What's the problem? The problem is the microphone. Is the microphone okay? It feels weird. So the problem is this guy shouldn't have had a heart attack. And, but he did. So if you just calculated his risk with the ACC AHA risk calculator, his risk of a heart attack would have been 4.1%. So he would not have even qualified for medical imaging or medications. How can we fix this? Okay, can you hear me now? I'm just kidding. All right. So if you look at the, that's much better. Thank you. If you look at preventive risk calculators, there's the ACC AHA calculator, and then there's the prevent calculator. And this one study, this was done in people that actually had heart attacks at young ages. And they looked at these people and 45% of them would have been missed by the ACC AHA calculator. 61% of them would have been missed by the prevent calculator. So what does that tell you about the calculators? They stink. They're really not great. They're good for populations, but they're not great for individuals. To understand what I'm about to talk to you about, it's nice to know the basic science that comes to plaque development in the arteries. What happens, what's the first step of plaque development in the artery? There are particles circulating in the blood that are atherogenic, and they get into the subendothelium and they create inflammation. And then monocytes come in there because there's inflammation and they turn into macrophages. This oxidizes these atherogenic particles. These atherogenic particles that become oxidized then attract T cells, and it creates more and more inflammation. Eventually, the body moves smooth muscle to try to wall it off, and calcification forms within the smooth muscle. And that's how we get calcium in our arteries. But what's the first step? The first step is we have lipoprotein B, ApoB particles. So we check a fasting lipid panel, but LDL is only one of those atherogenic particles. You can actually check an apolipoprotein B level, and that will tell you all of the particles in the blood that causes these atherogenic formation. So you'll notice here, one of those particles is lipoprotein A. I would highly encourage you to check lipoprotein A in your patients when you want to risk stratify somebody. But if you look at a fasting lipid panel, LDL usually makes up about 85% of these atherogenic particles. Lipoprotein A can be a big one in a lot of people. And that's a very genetic and independent of diet marker. In fact, when I have patients come in and I risk stratify them, I get a fasting lipid panel, I get a lipoprotein A, and then I'll do a calcium score on them. So, if you didn't hear about Willie Sutton in your medical training, you didn't listen, because Sutton's law is everywhere. It's kind of like Occam's razor, if you've heard of that. So Willie Sutton was a bank robber. A reporter one day asked him why he robbed banks, and he famously replied, because that's where the money is. So when it comes to looking at people's risk of a heart attack, we need to look where the money is. And the money is in the coronary arteries, and it's where the calcium, it's measuring the calcium buildup in the coronary arteries. And hopefully in the future, being able to quantify soft plaque. But Arthur Agatston was a radiologist, and he worked at Mount Sinai Hospital in Florida. And they got this awesome CT scanner. And they had the idea that they could look at the blood vessels around the heart. They used to do fluoroscopy or moving chest x-rays to see calcification. But he got this new scanner, and him and his radiology buddies got together and they started imaging their hearts on the CT scanner to see if they could see calcium, and they could. And they wrote a paper about it. And that paper was the first paper to show that you could look at calcium with the CT scanner and actually quantify it, give it a score. So this is kind of what a CT scan calcium score will look like. If you look at your image on your left, that you can see some calcification within the LAD, and that type of image is probably a score less than 100. If you're about 100 to 399, it's going to look like the middle image. And if you're over 400, it is just literally a white tube, just severely calcified. Very easy to see. One important thing to know about looking at calcium in the arteries is that a calcium score tells you risk, not stenosis. It's a common misconception that if you get a calcium score, you see calcification on a CT scan, that you're seeing blockages. Most of that calcium is actually within the wall of the blood vessel and is not obstructing the lumen. It only tells you risk. The first study, long-term study that really looked at risk of calcium scoring was the MESA study. It was done out of Wake Forest. And they looked at over 6,000 men and women of many mixed ethnicities and followed them for about 4 years. They looked at heart outcomes like death, heart attack, revascularization. If you look at their data, the image on the left is just death and heart attack. And you can see that the higher the score, the more likely you were to have something bad happen to you. The incidence after 5 years was about 6% if your score was over 300. If you look at all events like revascularization, stents, bypass surgery, death, heart attack, then you're looking at a very high incidence if your score is over 300. And that's about 11% over 5 years. This is not the MESA data. It was another study of about 38,000 people. And this shows you that calcium scoring, it does not matter your ethnicity, it's accurate. It does not matter your gender, it's accurate. So men and women both, it's a very good test for both men and women. One awesome use of this test, and the way I love to use it, is that if you calculate somebody's risk with one of these calculators, if you get a calcium score, you can actually reclassify them as being lower risk or higher risk for a heart attack. And what studies are showing is that a calcium score can reclassify 50% of people who you calculate their risk on like the ACC AHA calculator. So it is an awesome tool to help reclassify. The advantages of calcium scoring: it's extremely low cost. It costs, we're about to charge $149 for it. Right now we charge $175. It's low radiation, high reproducibility. It's widely available, and we have good data since 1990 on calcium scoring. Now, I don't want to poo-poo CT coronary angiography that looks at both calcified plaque and soft plaque, which soft plaque is not seen on a calcium score. It is unknown really how much better that's going to be at this point in time than calcium scoring, but you can pay $2,500 and get the CT angiography, or you can pay $149 and get the calcium score. And there are people who will pay big money for that CT scan of their coronaries. So I just want to go through some numbers with calcium scoring. And the first number I want to talk about is the score of 0. If you get a calcium score and your score is 0, what does that mean? So I saw this woman in my clinic. She was 45 years old, very good weight, blood pressure, heart rate, excellent. She has premature coronary artery disease in her family. Her dad had a heart attack at 54. Her LDL cholesterol is 168. If you just saw that LDL number, I'm just curious, how many of you would put her on a statin with that family history? Raise your hand. I think that's reasonable, right? Makes sense to us right now. So her 10-year risk of cardiovascular events, according to the calculators, is 1%. You can calculate her 30-year risk, and it's still pretty low. Should I take medications? So this is where the calcium scoring becomes extremely useful. If you go online, you can search MESA cardiovascular risk calculator, and it will come up with this very page. And you can put the individual's data in their age, gender, their cholesterol numbers, blood pressure, kind of their medications, their family history. And I just realized I made a mistake on hers. She does have a family history of heart attacks, so that would be a yes. But regardless, if you look down at the bottom, the risk is given to you based off the calcium score and the risk based without a calcium score. And you can see if her calcium score is 0, that makes her risk pretty much 0 over the next 10 years. And I would not treat her with a statin at this point in time. The calcium score test is the best test we have to individualize cardiovascular risk in people. And this study here looked at, yes. Yeah, hers were normal, her lipoprotein A. And what was the other thing you asked about? Yeah, her HDL was 80. Yeah, so the question is, what about her HDL and lipoprotein A? So her HDL was 80 on this, and her lipoprotein A was normal. It would be awesome to have a calculator with coronary calcium scoring and lipoprotein A all in one. It's coming. I'm sure somebody's working on it. But if you look at all the testing we do for risk stratifying people, how many of you have ever checked CRP in people to help risk stratify them? That was very popular. And then there's carotid intermedia thickness that you can measure. There's a few other things, but calcium scoring has the best power to individualize risk of all of these tests that we do. A score of 0 tells you that you have a very good life expectancy. You have a very low risk of not just cardiovascular disease, but cancer and other illnesses. So a score of 0 is incredibly good. If you have a score of 0, like this gal, I'm probably going to have her come back in about 3 to 5 years and repeat her test again and see if she has developed heart plaque. If somebody has a score over 100, and you'll find out why in a bit, I would not repeat their test. They're high risk. You're going to treat them. If somebody's between 1 to 99, I probably would do 3 to 5 years follow up with them too. And just know that if you put people on statins, statins actually accelerate calcification within the plaque. So your scores can be potentially higher. So if I put somebody on a statin, I'm really not going to check their calcium score again. We don't know what to do with that data. So that was a score of 0. 100 or more is a magic number for calcium scoring. So here's a guy, he was 59, his LDL was 168. If you plug his information into the calculator, his 10-year risk is 6.1%. So I did a calcium score on him and it was 110. So I put his information into the MESA calculator online. And if you look down at the top box there at the bottom, his 10-year risk of heart events was 9.1%. And that qualifies him now for statin therapy and other aggressive lifestyle changes. So a CAC score greater than 100 over time is a very good indicator that somebody's risk is above 7.5%, which is our threshold to treat people with statin therapy. And it happens in all ethnicities. This is a very awesome, powerful slide. I love it. It shows you, I think it was 10-year data, but it shows you if you treat people with statins or not based on a calcium score, which group has the best outcomes with statins. Is it the over 400 group or is it the 101 to 400 group? The widest difference margin is that 101 to 400 group. If you think about that, the group that is over 400 has very advanced disease. But if somebody's between 100 to 399, you're going to catch them at a time where their plaque is, you can stop a lot of disease by putting them on statins. You'll notice that a calcium score less than 100 in that top right corner for you is really not much benefit from statins over that 10-year period, but we got to think long-term, and in 30 years, I bet that's going to become significant. So I have a conversation with my patients if their score is less than 100, but not 0, that I would strongly recommend they consider a statin. The other number I want you to remember with calcium scoring is 75th percentile. If somebody's over the 75th percentile, they're also extremely high risk, just like a score over 100. So this gal, 48 years old, LDL 154, 10-year risk less than 5%. Her calcium score was 72. That actually puts her in the 98th percentile for her age and gender. She has very aggressive atherosclerosis at her age, and I would put her on a statin. And the stuff on the right is a calculator you can do online, and you can just see where you are if you get a calcium score for you or your patients. But in her case, they found that people with scores less than 100 that are greater than 75th percentile, it doubles their cardiovascular risk of events. The last number I want you to remember is 400. Anything over 400 is considered severe, very severe calcification of the coronaries. In this case, this was a patient that came to see me. Well, his wife made him come see me. His LDL was 160. His 10-year risk was pretty high enough for me to tell him to go on statins. But he didn't want to take medications. He didn't even want to be in my office, to be honest with you. So I said, well, let's get a calcium score on you. So here's this guy on the calculator. He's 66 years old. Let's pretend that his calcium score was 0. What would that do to his cardiovascular risk? So he would have gone from 10.9% just off a calculator. Score of 0 brings him down to 3.7%. I would not have put him on a statin at that point. But that wasn't his score. His score was 1,912. So that increased his risk to 10.9% to 25.8%. And I made him thank his wife for bringing him in there. If you have a score greater than 400, I would do a stress test on those individuals. About 20% of the population has silent ischemia, meaning they can go exert themselves and they will not feel chest pain or shortness of breath. But depending on the study, if you do a nuclear stress test on people with scores over 400, you will find ranges of anywhere from 6 to 23% of them have ischemia on their nuclear stress test. So the guidelines suggest that anything over 400 you would stress. Anything over 1,000 is very high risk for not just cardiovascular events, but cancer and other conditions, all-cause mortality. So it's a good prognostic test in that way. So a lot of our patients get CT scans without getting a calcium score. And is there any correlation between what the radiologist says is mild, moderate, or severe coronary calcification and calcium scores? And the answer to that is yes. So I look up CT scans on people that come see me all the time, because a lot of people that walk into the ER get a troponin and a CT scan, even with the stub toe. Are there any ER doctors here? I'm sorry. But I had this lady come see me, and she had a very low 10-year risk by calculators. And I looked at a CT scan that she had had in the ER. And this was her CT scan image. And what do you see? You see calcification within the left anterior descending and a branch off that, the left circumflex. And she has calcification within the left main. She said, nobody told me I had anything wrong with my heart when I went to the ER. But our radiologists here at St. Al's they've done a quality project to try to be as consistent as they can be and to call things mild, moderate, or severe. And these are just images of what mild, moderate, and severe look like. The good news is that if a radiologist says moderate, what they're saying is that this person has a score greater than 100. And so I would treat them as if they had a score greater than 100. Any questions about that? Most people have had calcium scores. It's called mild, moderate, or severe. There's good correlation between what a radiologist subjectively calls mild, moderate, and severe, and a calcium score done with Agatston quantification testing. So exact agreement was noted in 73% with those categories where I said mild, moderate, or severe. Mild is less than 100, moderate is 100 to 399, and severe is greater than 400. So do I do calcium testing on? Here's what the guidelines suggest. If somebody's over 40 years of age and they're asymptomatic and they're in intermediate risk, if you do a calcium score on that individual, you will reclassify the risk in 1 in 4 people. If there's risk by calculators is 5 to 7.5%, and they have a family history of cardiovascular disease or other accelerant of atherosclerosis, such as some inflammatory autoimmune condition, they say maybe. So, guidelines, if you practice the guidelines, I had a professor in my fellowship who said, you're just a C doctor, you're earning Cs. So just look at the numbers. If somebody's less than 2.5% risk by a calculator, you have to do 79 calcium scores to reclassify one person. Probably not the best use of resources. If somebody's 2.6 to 5%, you've got to do 44 calcium scores to reclassify one person. If their risk is over 20% on the calculators, you don't really need to do a calcium score. They're high risk. Symptomatic people don't need calcium scores. They need stress tests. So, any questions so far? Yeah.
Raise your hand. So if someone's calcium score is over 100, do you automatically put them into the secondary prevention category? So you're doing high dose statin?
Yeah, because their risk is at least 7.5%.
Under 100, you still call it primary prevention?
Well, technically it's all primary prevention, but I look at like a diabetic, we treat them as if they've already had a heart attack. That's how I look at these people with calcium scores over 100, that their risk is that high.
We had a question from someone online. Can you please ask if calcium risk score is covered by insurance for the calcium score? And if so, what's the billing code?
Because it's so cheap here, we've stopped trying to get insurance companies to pay for it because they never did. And they don't, as far as I know. It's $149 at St. Al's. All right, it's $175 final. Just give them $25 and tell them to come down here and make up the difference. Other questions?
I have another question. So how is a calcium score different than just a regular old CT scan? What's the procedure involved?
Yeah, good question. So what's the patient preparation, and is that what you mean? Compared to a normal CT scan of a,
So if you're going to do a calcium score on someone, they're going to have a CT scan. I mean, is that a special type of scanner, or what's the procedure, and how does that compare to just a routine, okay, I'm in the ER, okay, I had a stub toe, I need a CT scan?
you've been listening, I'm so impressed. They have to use a certain slice CT scanner. And I'll just tell you my experience. I walked in, kept all my clothes on. I sat down underneath the CT scanner for 5 seconds and I was gone. They don't need to do any heart rate control, just a simple CT scan, just like that. Does that answer your question?
Yes, thank you. Oh, and where are they done? And
Just in the radiology area here at the hospital.
and what's the procedure? Do you have to have a referral from your primary?
No, well, yes, I don't think you can just walk in and get them done. Like you would have to order it for someone, or if you wanted one yourself, you could have your colleague order it for you. Because it's self-pay, it's, you don't need codes. Yeah.
Emergency room, can you do the different slicing to look for a calcium score?
That's a good question. To score it, I'd have to ask the radiologist that. I really rely on them for mild, moderate, and severe in these cases.
It would make sense that you could do that and save the 145 or the 175 or whatever.
Yeah, well, they charge you for doing it on the back end if you asked them to do it.
It might be something you could do easily.
Yeah, no, it's a good question. I can talk to the radiologist about that. It's good. Yeah.
Have you had any success with getting GLP-1 coverage by claiming ASCVD based on a CAC score?
That's a good question too. So can I get GLP-1 coverage based off a calcium score? I have not tried. We use clinical cardiovascular disease for that events, but good question.
Then for patients that have a CAC score greater than 400 and you've done the NUCMED stress test, how frequently would you repeat that?
There's no guidelines on frequency of repeating a nuclear stress test after a score of 400. In my practice, or at least what I do, is every 5 years seems reasonable to me. And if they can exercise, I'll put them on a treadmill, but then do imaging with it. When you do treadmills, you miss probably 50% of people with ischemia. After a stent, the guidelines suggest doing it in 2 years, a nuclear or a stress test with imaging. After bypass, it's 5 years. So, and these people who are asymptomatic, never had a heart attack, I just say 5 years. That's the art, not the guidelines of medicine right there. So, yeah.
The recommendations for testing for cholesterol have changed this year, I think. So what are your recommendations when you get like a 25 or 35-year-old patient that has a elevated LDL and triglycerides?
As far as calcium scoring goes,
Or just statins?
Oh.
There's no calculator.
Oh, I see. Yeah, well, there's no guidelines in regards to these kids, unless they have LDLs that are kind of in that familial range of 190. There's no guidelines to suggest treating them. The only other way I'd treat somebody who is that young is if they had an elevated lipoprotein A. And the upper level for a lipoprotein A is 30. Anything beyond that just increases your risk of cardiovascular events. So I mean, just the other day, I had somebody come see me with a lipoprotein A of 200, and they were in their late 20s, and I recommended they go on statins. So a calcium score would be highly unlikely to show any calcification in somebody that young, which is why the guidelines say 40. Because if anything, they're laying down soft plaque. I mean, when they do autopsies on Iraqi soldiers and Vietnam soldiers from the US, they had fatty streaks in there at that age. Even babies that have died of sudden infant death syndrome have fatty streaks in their arteries. I mean, everybody has soft plaque. So, yeah, does that answer your question?
We'll do one more question and then continue with your talk, and then we'll take some more questions at the end.
Okay.
Is insurance covering LP little a, and what's the cheapest way you find to get that done?
I've never had a problem with that being covered. At least patients haven't said it isn't. I mean, I order them, and just like I do with fasting lipid panel, and it's done. I've never had a patient complain that it wasn't covered. I mean, I'm ordering it for premature coronary disease in the family, and that's my diagnostic code I'm using for it. There is one other hand. No. All right. When am I supposed to be done? Okay. All right. So what is the data behind medical therapy for different calcium scores? So if your calcium score is greater than 100, just remember this number needed to treat over 10 years. That number is 12. I have to put 12 people on a statin to prevent heart attack, death, or stroke. One in 12 people over 10 years. So do statins work in general to prevent cardiovascular disease? This is a meta-analysis where 90% of the statins in the studies were medium dose, medium intensity statins, simvastatin and lovastatin. And these people all had coronary disease, as do the people that have abnormal calcium scores. The number needed to treat over 4 years to prevent death or MI was 26 people. So that's a very powerful number. 1 in 26 over 4 years. And that's just with moderate intensity statins. This study, the Prove It trial, was part of the Prove It trial series. They actually compared like a low intensity or moderate intensity statin like pravastatin 40 to a high intensity statin like atorvastatin 80. And they found that even just, these groups that were all taking statins, the better statin, the stronger statin, the number needed to treat to prevent one heart attack or death was 26 over 2 years. High intensity statin therapy is powerful stuff. And there's been some wonderful studies that have looked at coronary arteries 1 year after going on high intensity statin. And it does two things to plaque in the body. It shrinks it, and it puts a protective cover over the plaque of calcium to keep it from erupting like a volcanic eruption. And so these medicines work, no matter what the internet says. They work. What about aspirin? If somebody has a calcium score greater than 100, the number needed to treat to prevent one heart attack is 1 in 92, which means that 91 people, I'm sorry, I didn't write the duration in here of this study, I should have. But the number needed to harm with aspirin and a calcium score greater than 100 was 1 in 442. So there is a very slight benefit, but I'll tell you, this benefit is really small. I tell my patients all the time, a statin is your best medicine to prevent a heart attack. Aspirin is not. If your calcium score is 0, the number needed to treat for aspirin is 1 in 2,036. Not worth it. Number needed to harm is 1 in 442. So calcium scoring can be very beneficial, not just with statins, but with aspirin. So let me just really quick talk about the lifestyle I talk to my patients about. Smoking is, the data is so good with smoking. If you stop, the number needed to treat to prevent a heart attack over 9 years is 11 people. If you get 11 people to stop smoking, you'll prevent a heart attack in one of those people over 9 years. It's about the same as getting somebody to take a statin. I don't know what the number needed to treat as statins and if they continue to smoke. Who knows? But what about smoking anything? Marijuana, vaping, chewing tobacco, secondhand smoke all have data to suggest that they increase your risk of cardiovascular events. So I tell my patients to stop smoking anything. What about weight loss? Does weight loss prevent cardiovascular disease? There really has been no large long-term study looking at weight loss and cardiovascular disease prevention, but it makes sense, right? When you lose weight, you reduce cardiovascular risk factors. And this data here is just observational data showing that the bigger we are by BMI, the more likely we are to have coronary heart disease events. So what do I tell my patients about waist loss, not weight loss? I talked to him about this guy named John Cisna. Has anybody read this book, My McDonald's Diet? This guy was an Iowa science teacher, and he and his science class watched the documentary Super Size Me. So you all watch movies and you don't read books. That's what I'm learning about you. So anyway, they watched that, and Mr. Cisna told his class, I bet I could lose weight eating McDonald's every day. And they said, bet. And so he took him up on it. For 6 months, all he did was eat McDonald's for breakfast, lunch, and dinner. It helped that his friend in town ran the McDonald's and he got his meals for free. But his class came up with the meal plans for him to keep his calories at 2,000 calories a day. And he would walk 45 minutes a day. How much weight did he lose at the end of the 6 months? So here in the book, he says 37 pounds at 90 days, but for the 6 months, he lost 56 pounds eating McDonald's every day. What's the message? You can eat M&Ms every day and still lose weight. And that's pretty much what he did. He ate processed foods for 6 months and he lost weight, and everything in him got better. So what I tell my patients is all you need to do to lose weight is know 3 things. And you don't need GLP-1s. And I always ask them, do you want to lose weight or do you want to keep it off? And I know somebody's going to get offended at that, but it's true. We have never been successful helping people keep weight off with medications. And I don't expect GLP-1s are going to be any different. They're incredible medicines, and they're probably going to be the most prescribed medicine when they go generic in the world because they really work. But the 3 things are this: know how many calories you need to eat a day to lose weight. For most women, that's 1,600 calories. For most men, that's 2,000 calories. But you can use artificial intelligence to tell you that. If you put in your statistics, how much you exercise, it will spit out how many calories you need to eat a day to lose weight. And then I talk to my patients about the 400 calorie rule. And this is, you can modify it as you will, but if you're going to eat 4 meals a day and you're a woman, just make sure they're all 400 calories each. Most people eat the same foods. So just know if you like these 5 breakfasts, how much you have to make for that breakfast to make it 400 calories. How much do you have to make for the lunches you like to make it 400 calories, et cetera. And you can divide that out any way you want. But if you fail to plan, you plan to fail. The last thing you need to know is that when you lose weight, you need to exercise to maintain your muscle mass, and you need to you do need to eat protein. And I think we might be eating too much. It's very trendy right now to go protein. It makes me lose my appetite when I go to restaurants and they ask me what protein I want. I'm like, it's meat or it's plant protein, whatever. But when I tell people to exercise, I tell them to strength train and to eat about half their body weight, pounds and grams of protein. What about blood pressure? I still use the SPRINT trial only because this is my population of people. These are people with cardiovascular disease. The average blood pressure that showed good therapy or good outcomes was the intensive arm, which had an average systolic blood pressure around 121 millimeters of mercury. The trial was stopped early at 3.3 years. The number needed to treat in the intensive arm was 1 in 63. So not great, but not bad. What about blood pressure? These are all the things that have been shown in observational or randomized controlled trials to lower blood pressure. And I will go over these with my patients. What about food? How many of you have heard of the Leonhardt study, Mediterranean diet? It is truly the only randomized controlled diet over a long period of time that showed a significant benefit to a diet when it comes to preventing cardiovascular disease. And the number needed to treat over 27 months was 12 to prevent a heart attack. The number needed to treat over 5 years was 5. That's better than statin therapy. This was their diet. Are these slides going to go out to the people? Sure. You can send them. So Anyway, this was the diet there on your right. Mediterranean diet. What do I tell my patients about food? I just say emphasize healthy fats found in fish, nuts, and plants like avocados, beans, seeds, legumes, fruits and vegetables, whole grains, plant-based proteins. These two diets here are associated with more cardiovascular disease. They're labeled the Southern diet and the Western diet. Who knows what the Southern part of the US is called when it comes to strokes? Have you heard of this? Stroke belt? Yeah. And then what do I tell my patients about exercise? The number, I say, just remember 3 numbers, 1, 2, and 3. If you walk once a day, that's great. The company that invented pedometers in Japan, the company name had the number 10,000 in it. And so they thought it would be cute to say, go walk 10,000 steps a day. And that has perpetuated. There's some good studies lately in the Journal of the American College of Cardiology that shows about 8,800 steps a day is anything beyond that really doesn't provide that much more benefit. 8,800 steps is about 4.5 miles a day. And that can be preferably cumulative throughout the day. The second thing I say is strength train 2 times a week for 20 to 30 minutes at a time. And number 3 is to do aerobic or HIIT type activities 3 times a week for 30 minutes at a time. 1, walk once a day. 2, strength train 2 times a week. 3, aerobic exercise 3 times a week. That frequency, that type of exercise is the best amount and type of exercise to prevent cardiovascular disease. So I think that's all I have. Any questions?
We have about 5 minutes left for questions. Thank you. I'm going to ask a question that came in online. Difference in radiation between the coronary calcium versus just, I've come in through the ER, I stubbed my toe, I got my CAT scan. Difference in radiation between the 2 studies.
That's a great question. I should know that. It is very low. Yeah, that's a great question. You could probably just look it up on AI and it will tell you, but it's really low.
ChatGPT, here we come. Question here.
Thanks, Dr. Nelson. So I'm one of those ER doctors that will order CT scans and find
That's why I said it.
findings. So I'm curious, how would you recommend that we counsel patients on this? Because a lot of times we'll see people with trauma that have no PCP, say they have no past medical history, and then the radiologist will call either mild, moderate, or sometimes even severe coronary calcifications. Would you like all those people that have some degree of calcification to go see cardiology or just back to a primary care doctor for lipids and, you know, an overall risk assessment?
Well, I would say if it was severe, send them to cardiology, because again, it correlates with that 400. This is just my opinion. So correlates with that 400 where there is silent ischemia possibly going on. But I would say mild to moderate can go to their PCP and talk about statin therapy.
Thank you.
Thanks.
I think the answers will be easy, so I want to sneak in 2 questions.
Sure.
The first one is people who take statins, the question's about side effects. Are CPKs monitored, or do you only do that when they are getting muscle symptoms?
Yeah, I just do it with muscle symptoms. I'll check liver once.
Got it. And then my next question is, we're getting conflicting information. Like if you remember a movie from the 70s, Sleeper, where he wakes up and they tell him that cigarettes are the best thing for you. We're getting that kind of information now. What's your opinion on seed oils? And now we're eating meat and butter. I have friends who are vegetarian and are eating meat now because they're being told that all that animal fat is good for them.
Yeah, well, I mean,
My main question is the seed oils.
well, what I can say is the best oil, the most studied oil is olive oil. And oils that have a similar fat profile to that, like avocado oil, that's what I recommend. I really have no opinion about seed oils. I will say that in the Leonhardt study, they did use canola oil. And that has gotten a bad rap with some people who come in and say they'll never do canola oil, but you know.
Because the weird thing is you'll have people advertise, we don't use seed oil. And I'm like, yeah, okay, thanks.
Yeah. When you think about food, think there are foods that are neutral. They don't cause heart disease. There are foods that do cause heart disease, and there are foods that protect you from having heart disease. A lot of the foods that we have been told cause heart disease are probably neutral. And a lot of the foods that we have eaten for a long time because they're cheap and taste good, ultra-processed foods, that probably is very much associated with cardiovascular events.
But don't you think these ideas now that eating animal fat is good for you are not a good idea? Don't you think that's crazy?
Well, the main message in nutrition studies is that the more plants you eat, the better off you're going to be. But I don't tell people not to eat animal meats or fats. Again, I think most of that is probably neutral. When you process animal stuff, then it becomes very unhealthy for you. Like bacon is probably not very healthy for you. But we had that for breakfast today here, I noticed.
And I enjoyed every bite.
Good. Yeah. Well, I'd rather, live 2 years less and eat bacon than live 2 years longer.
Here.
Right?
Maybe we'll take one or two more questions. Here we go.
I have a unique population in that I've treated HIV patients. And the HIV patients that I have been treating since the early 80s tend to have coronary artery disease. The protease inhibitors encourage it. And I have on occasion, well, I had one who died of his coronary artery disease, and I'm limited in what statins I can use because of the interference with the drugs, which usually means pravastatin, atorvastatin at a lower dose. My patient died after I raised his atorvastatin to 80 because I really didn't have anything else. And I also had to change his drugs because they no longer did the ones that he'd done so well on since the early 90s. But my last patient, he had atypical chest pain. I sent him to the cardiologist, and I'm not sure if he didn't realize from the drug, which was Biktarvy, that he was an HIV positive patient. He basically did nothing, and then the guy started running up a hill and he died of an acute MI. What should I be doing with these patients? Should they be starting on calcium stuff without symptoms at an early age, maybe 10, 20 years of HIV therapy? Because these are patients that were started in the 80s and 90s that I've had experience with.
Great question. So the HIV population has an accelerant to atherosclerosis, and with accelerants like autoimmune diseases, inflammatory diseases, I have a lower threshold to put people on statins. The best statin is rosuvastatin. It has the least amount of side effects. It's the most powerful. What I would also suggest is that lifestyle has no side effects and is more powerful than statins. And I would be very forceful with them about living a healthy lifestyle. Good. I would reinforce that. So. Sure. Yeah, calcium score, feel free to order it and that data. Sure. Sounds like you're thinking right about it. I'd get a calcium score, help you make decisions and reinforce the need for adherence.
Dr. Nelson, thank you.
Thanks.
This has been fantastic. And at some point, I'll have you over for dinner. So. All right. Well, we are very pleased to introduce Dr. Layla Soliman as our next speaker. She completed her undergraduate degree at Wayne State University, earning a bachelor's in psychology. She attended medical school at the Medical College of Ohio in Toledo, Ohio. Dr. Soliman then went on to complete her residency training in general psychiatry and fellowship training at the University of Pittsburgh Medical Center in Forensic Psychiatry. She is board certified in both general and forensic psychiatry. She teaches medical students and residents, and she is an assistant clinical professor of psychiatry with Atrium Health, Wake Forest School of Medicine. In addition to her clinical and academic work, she serves as the medical director of quality for the behavioral health service line. She is a nationally recognized speaker, and her career has been focused on utilizing the principles of suicide and violence risk assessment to optimize patient care. And we're lucky to have her here with us today, Dr. Soliman.
So I've had a couple of tough acts to follow this morning. Is the microphone placement okay? All right. So I'm going to start out with a brief background story and disclaimer. First of all, I'm like really nervous. I know she said I'm a nationally recognized speaker and all that, but I've been running around telling everybody for the past couple of weeks that I'm going to Boise to give a talk and that I have to do a good job because I was invited by one of the brightest people I've ever known. I went to medical school with Dr. Nelson, so I have to do a good job. The second thing I have to tell you guys is that I'm a nocturnist, so it is the middle of the night right now. I work third shift in the psychiatric emergency room. Oh, a little bit closer? Okay, are we good? All right. This is supposed to say, I kept fiddling with the title until I messed up the slide, One Shot, Opportunities for Intimate Partner Violence, Risk Assessment, and Intervention in Healthcare. So we're going to be talking about intimate partner violence, what we used to call domestic violence. Much to my chagrin, I have no financial disclosures. Anybody who knows how I can get some, please tell me after. And I broke this into two parts. We've got the scope of the problem and there's objectives that just are for part one, okay? And we're going to talk about the prevalence of intimate partner violence, or IPV, and the role of firearms in both fatal and non-fatal incidents. A part of my work has been firearm injury prevention. Next, we're going to identify the indicators that somebody's at higher risk of intimate partner homicide, okay? Because there are some clear indicators for that. And recognizing the non-fatal sequelae of intimate partner violence that might bring somebody to clinical attention. So I know we did this earlier, but brief show of hands, how many people are physicians or APPs? Okay, wonderful. How many of you are primary care? Okay. How many people can recall in the last couple of months somebody they've seen where intimate partner violence has been a factor? Okay, all right. So hopefully I'll give you something you can take with you. So according to the CDC, 41% of women and 26% of men have an experience in their lifetime with intimate partner violence, but this is likely an underreport because it relies on the person reporting that not only that they experience it, but they have some related impact from it. And a very common defense mechanism of coping with anything, any trauma, is to minimize its impact on you, okay? So something to keep in mind. So what are we talking about here? That's the other thing, is that there's a lot of different definitions that get thrown around. The CDC and the World Health Organization have roughly the same one, so I didn't bother putting both of them in. So this is abuse or aggression that occurs in a romantic relationship, but it can include a former partner, okay? This can be physical, sexual, psychological, with coercive control type of things, and stalking are some examples of things that can come into play here. So here are some numbers from the CDC on homicide. 20% are by a current or past intimate partner. So think about that. 1 in 5 homicide victims where the perpetrator in the relationship is known, that the perpetrator-victim relationship is known, are by a current or past partner, okay? Over 50% of femicides are by a current or past male partner. One of my colleagues who was an emergency psych used to say, if a woman disappears, we need to just lock up the husband or boyfriend and tell them, we're sorry about your civil rights. Once you're cleared, we'll discharge you. We'll let you go. I'm a little more constitutionally minded than that, but by far and away a current or past partner. And it doesn't even, this says male partner, but honestly can be a female partner as well. It's going to be the perpetrator. So, and then you've got the relationship between the victim and perpetrator not always being known. So again, likely leading to an underestimate, especially if it's a former partner that may not be immediately known. Okay, so what are some things that put somebody at risk of either being a victim or a perpetrator? Lower level of education, okay? A lot of times this means less options, right? Childhood maltreatment or witnessing family violence. This is huge in terms of predictors, okay? Harmful alcohol use on either side, unequal gender status, again, anything that shifts the power dynamic, right? Less access to paid employment for women, right? Especially in some cultures and subcultures. Marital discord or dissatisfaction, and communication difficulties between partners. Now, that last one makes it sound like if you learn how to talk to your partner better, they're not going to do this. That is not the point of it. These are just predictors, right? We're not in any way blaming a victim or anything like that. We're just trying to identify risk factors. All right. Perpetrator risk factors. Antisocial personality disorder. Guess what? Violent people are violent, right? And if you don't have a, if you don't kind of empathize with other people naturally, or if you're not able to appreciate a perspective, or you're irritable and your disorder has you already tending to externalize blame, you're going to be at higher risk for this behavior. Harmful masculine behaviors and attitudes. Again, most of the research focuses on male perpetrators and female victims. That probably needs to shift. But what I'm telling you is sort of what we have right now. I always like to, when I give this talk and when I talk about firearm violence, say we've got to walk in the world the way it is, not the way we want it to be. We are getting more research. But when you look at, and again, this is global, so other countries, other populations, these are risk factors. I should probably tell you, I'm married to a man, I'm raising 2 boys. So as much as some of this sounds like it has a bias, this is just the data we have. Who perpetrator risk factors specific to sexual violence? Again, belief in family honor, sexual purity, male sexual entitlement. There are cultures and subcultures. And again, this doesn't even get limited to what country you're in. It could be, within different parts of the US where there's this really idea that you belong to your spouse. And so, it's only been recognized, the idea of marital rape has only been recognized for maybe 3 decades in this country. So think about the rest of the world as well. And weak legal sanctions for that sort of thing. Okay, so how does this happen, right? It's kind of like, and I've seen this with both in my clinical work, with perpetrators and victims of either gender. It doesn't start out like this, right? You kind of start out, you're seeing somebody, it's new, it's shiny, right? They're putting their best foot forward, love bombing, things like that. Okay. And then when it does happen, very quickly you enter a honeymoon phase. So again, you're like, okay, there's the person I got involved with. They're back now. This was just a blip on the radar, or they're really sorry this time, right? Interestingly, though, while that's true, and a lot of times it's well into a marriage that something will come up, or long into a relationship, if it does come out in physical form during dating, those cases are more likely to have more severe violence and more severe physical injuries. But it often starts out subtle, right? I'm just tracking your location so I know when to expect you home, or I just want to make sure you're safe, right? So what'll happen is you'll have a calm phase, tension is building. Maybe the perpetrator is showing more signs of stress. There will be a violent incident, and then there will be a makeup honeymoon period. calm phase, so on and so forth, okay? So why doesn't the person leave, okay? When's the highest risk time for somebody to be killed? Sorry? Okay, so you're talking about restraining orders? That's a common indicator. In general, okay, it is in the beginning of the leaving phase. And by the beginning, I mean that whole first year, okay? And then it goes down. It doesn't go away. We've probably, I don't know how many of you watch the news in terms of, crime, but, we had one, I think 3 months ago, where the man went and stabbed his ex-wife, who had long since remarried. They'd been divorced, like, I think 17, some outrageously long amount of time, right? So you just don't know. Do you guys remember the Betty Broderick case going way back, late 80s, early 90s? Okay, I see some nods, right? They'd been divorced. The man had gotten remarried to his affair partner. And Betty Broderick herself had a boyfriend, or what we'd now call kind of a situationship. And so by any metric, you would think, the risk should have been going down. And I'm not saying, by the way, that she was a perpetrator of intimate partner violence prior to that. I don't know. I think that's one of those cases where, there's a lot of back and forth, but she was certainly a perpetrator of intimate partner homicide. So destabilization. So what are some other risk indicators for intimate partner homicide? Violence toward the female partner, even if she's the one who kills him later, right? So every now and then you'll hear in the news that a woman has killed her male partner and is saying it was because he was abusive. And, she kills him while he's sleeping because she believes that's the only way she can get out. Okay. Or if that's the defense, obviously everything has to go through trial and things like that. Destabilization. So again, separation, divorce, unemployment. Okay. Threats toward other family members, and firearm access. Firearm access is an independent risk factor for suicide and homicide. Again, I'm not uncomfortable with guns. I'm pretty comfortable with handguns, actually. I know how to use one and everything. But this is where the data are. And so if you can do anything in a case where you are concerned about suicide or homicide, to secure a firearm, that is one of your highest yield interventions. All right. When you're taking a history from somebody who is telling you that they've been a victim of intimate partner violence, and they won't self-identify that way, by the way. A lot of times you've got to get to it through other questions, and they're not going to have conceptualized it in their mind yet that they're in an abusive relationship. If they've ever been strangled by their partner, they're at high risk. Physical violence toward a pregnant victim is a high risk indicator. Stalking behavior, and suicidal ideation or behavior on the part of the perpetrator. One little known, little appreciated fact, although we're getting better about it, is in the broader context of suicide and homicide risk assessment, there's a great deal of overlap between risk factors for suicide and homicide, or even just suicide and serious violence. Am I still too far from the, okay. All right, how's that? Okay, I'm trying to balance, correcting for my height and the microphone level. I can't wait to go home and tell my husband that people said I wasn't loud enough. Okay. So special cases. What about the elderly? How many of you see folks that would be considered in the geriatric population in your practices? Okay. This is an overlooked population. Okay. There's 3 fundamental themes from this article that I like by McGarry. And by the way, if you are, it was quoted in the one by Gerino, if you are looking for light reading, I'm more than happy to send you a bibliography later. Hiddenness, can the victim talk about it, right? There is already now still a great deal of stigma. Imagine for somebody who has been married 40, 50 years, where that stigma level is compared to where it is for our generation, right? Longevity, how long has this been going on? How used to it is the victim? And the changing nature of IPV over time. So again, this is not always physical, right? So coercive control, continuing to degrade somebody or yell at them. And there's really a lot of learned helplessness where somebody feels trapped and feels like they can't escape. So specific risk factors: economic instability, belonging to an ethnic minority. I'm Egyptian. I can tell you quite a bit about the differences in how marriage is seen in my family of origin versus society at large. Cognitive or physical impairment, interdependence on, if people are enmeshed, right, there's a higher risk of violence. Intergenerational violence, if you see that, again, patterns, generational trauma, the risk perpetuates. Caregiver stress. There was an elderly man who killed his wife and said, I think anybody would understand that I would rather spend the rest of my life in prison than having to care for her in this state. Again, I don't know how many of you are crime folks like I am. Forensic psychiatry will do that to you. And substance abuse in either partner, okay? All right, so protective factors in the elderly. Social support, right? Which is actually awesome for any age group. Help-seeking behavior on the part of the victim. If they can self-identify or at least identify that they need help, they're in a much better position. The presence of community-based service, right? We can do all the screening and all the education to help people self-identify that we want. If there's no services to back it up, what are we doing, right? And I thought this was sort of a funny finding in this paper, so I included it. Becoming an immigrant in Canada. So you can get legal immigration status in Canada, you're in better shape. So let's talk about men for a minute as victims of intimate partner violence and barriers to help, okay? And I've noticed a couple of things with the men that I come across who show indicators of having been victims or survivors of intimate partner violence in my practice. They almost never self-identify, right? The ones that do, and I work in an emergency setting, are kind of at a loss because again, you look at them, what resources do you have, right? Some cities will have shelters for this for men and have put aside a few beds, but not many, right? If the perpetrator is arrested, and again, perpetrator could be male or female, it's just their intimate partner, they are less likely to not repeat the behavior, okay, than if a male perpetrator against a female victim is arrested, okay? It's not great numbers for anybody, but you've got a better chance of reducing recidivism in a, with a female victim and a male perpetrator. Police are or are perceived to be less empathic. I think in a lot of cases that perception is well grounded in reality, right? And you get a risk of subsequent legal abuse and counter charges, right? And of course, custody issues. Just a brief question before I tell a vignette. Is this being recorded or? Okay, it is. All right. So I'm going to just keep the details very sparse then and mix a few cases. Some of the things that I will hear is she said that if I tell anybody, she's going to accuse me of hitting her, of threatening her with a gun, of, these other things. She says, I'm never going to see my kids again. She says, that she can see what I'm doing. Now with the Ring cameras, people are putting them more commonly inside the house. Ring, Nest, I don't mean to call out Ring specifically. And so these are some of the things that you hear. Sometimes it's physical, but it's less frequently physical in this direction. And when it is, it's a very tough position because the average guy is still stronger than the average lady. Now, again, no sexism intended, right? So it can be a really tough spot. You're really not allowed to hit somebody back, right? And I've seen plenty of cases where both parties get arrested and the truth is unknowable, you know, when you're seeing them in a jail doing a competence assessment, which is something else that I used to do. All right, so moving right along, I just want to make sure I'm good on time. So what about guns? After all, the title of the talk said one shot. I don't want to disappoint anybody. We'll talk a little bit more about guns. Very common instrument of coercive control. The risk of death for the victim goes up 5-fold if there's easy access to a firearm. You know, we can have an argument about whether people snap or not, but I think we can all agree that it is a very lethal, very quickly usable method. And of 298 female victims, so almost 300, a quarter of them had been threatened with a gun. And these are just the folks that pressed charges and went through the criminal system, okay? Again, all right, how about that? Better, okay. Just keep me honest, guys. Tell me when I need to move. All right. So the most recent Supreme Court ruling that addressed firearms and intimate partner violence was Rahimi. Okay. Anybody familiar with this? No? Okay. So this guy, you know, if you wanted to create a dating profile, he could be your model, right? This was a gentleman who was subject to a restraining order, but when you actually read the filing, had racked up like all these gun-related charges, discharging a firearm in a public setting, possession of a firearm by somebody who's not allowed to have one, breaking a restraining order, just this list. And finally, he manages to get some federal charges for owning a firearm or possessing a firearm while he's subject to a restraining order. So he said, that's not fair. That should not limit my Second Amendment right. And so the appeals court was all ready to rule in his favor. And then Bruin, another Supreme Court case before that was decided coming out of New York, that said you have to have a historical analog for any gun law that's, you know, limiting somebody's ability to carry. It's sort of the history and tradition standard, if anybody else here is legally minded. And so then the appeals court said, well, okay, we better rethink this ruling, and they ruled in his favor. So went up to the United States Supreme Court, and they said, actually, if there's a credible threat, you know, that's been kind of adjudicated and verified by a court to the physical safety of another person, you can temporarily disarm somebody, and you're not, you know, you're not breaching their Second Amendment right. So this allowed extreme risk protection orders or red flag laws to continue. Are folks familiar with what those are? Idaho does not have one. I looked it up. It came close to having one, but. So basically a red flag law is when somebody is at significant risk of violence or suicide, depending on how the law in that state is written, they can be temporarily disarmed, okay? All right, so moving right along to part 2. So what's at stake here? What are some of the sequelae of intimate partner violence? Depression, post-traumatic stress disorder, suicidal ideation, traumatic brain injury with or without cognitive impairment, right? And the greater the deficit, the higher risk that person is of re-victimization and not being able to get out. And children who are exposed are at a higher risk of future intimate partner violence, either as perpetrators or victims. Substance use, depression, suicide, etc. Right? A brief comment on my why. Okay. I mean, there were lots of reasons for me to get interested in this. One was seeing a friend of mine be completely destroyed by this, and going through ongoing sequelae and re-triggering via litigation abuse. Despite having been divorced for a decade, devastating economic consequences, not to mention having been a victim of physical violence. And so having seen that front and center in my own life, and having her say to me, because she'd stopped talking to me for, you know, maybe 7 or 8 years, and then we reconnected. And one day after we'd really been reconnected for a while and had gotten really close again, she said, I'm sorry I stopped talking to you. I knew that what you said about him before I married him was true, which was just, I had no idea he was going to do that level of, I just had concerns. And she said, I'm sorry I stopped talking to you. I knew what you said was true, and the cognitive dissonance was just too much for me. And so she didn't feel like she could reach out until she'd left. So that's, something that I keep at the center in this type of work. So what's the cost to the victim? We already talked about the higher risk of suicide, chronic pain, cognitive issues, which of course limits somebody's ability to be independent. Sexual abuse can lead to STDs and long-term injury. PTSD, as we already said, the sequelae can perpetuate the problem. Again, the more severe the consequences, the harder it is to leave. And the harder your dependence is, the higher your dependence is on the very person who's presenting the greatest danger. Health outcomes, 70% increase in risk of cardiac disease, okay? 60% increase in the risk of asthma. So these are very real physiologic sequelae. 70% risk of excessive drinking. And if you've got a TBI, undiagnosed, because it's not immediately visible or obvious to first responders a lot of the time. So again, there's some light reading at the bottom for you if you're so inclined. So what are some considerations in assessing or treating intimate partner violence? And there's a model, trauma and violence informed care instead of just trauma informed care. And it considers it from a multi-layered ecological approach. It's equity oriented, and it looks at how the people who are already marginalized are more vulnerable to IPV, okay? So where do we fall down in our screening, right? Male victims, people in same-sex relationships, men or women. And in the lesbian community, I've seen some really bad IPV that gets overlooked because people don't think to screen, okay? Elderly, past all that, not at all, okay? And people who are just, really good, like most of us are, at putting up a front, right? So screening is only as good as the resources that we have to back it up, and less resourced communities have less resources in general, right? If you're in a poorer community, if you're in a more outlying community, there's just going to be less of everything. So a lot of this comes from the journal of pointing out the obvious, I'm afraid. So what drives the perception of providing and receiving intimate partner violence care? I just want to make sure we're good on time, because I do want to talk about a couple of cases at the end. Clinician comfort level, okay. Empathy, which is fairly innate. Some of us may feel a great deal of empathy, but our mannerisms are our mannerisms. I'm very direct in my communications with people, and so I really kind of have to watch it when I'm talking to people in the emergency room and trying to draw some information out. Skill, so you can learn how to do this. Institutional factors, what's your physical space like, right? I've been in ERs where there's just curtains, separating, and I can hear everything that's going on. And ones where there are, individualized rooms with doors. How many people are available? What's your personnel like? Are you chronically short-staffed? Are there 30 people waiting to see you? And in some cases in the psychiatric ED, the place is packed. And I'm sure just like the regular ED, there's times that it's packed and times when it's a little more reasonable. The availability of types of care on site. This is a challenge in our setting. We can't do any sort of radiology. We can't do proper stat labs. It takes 4 to 6 hours, right? So I need to medically clear somebody. I need to have them sent to the big ED, 10 minutes away by ambulance. What does that do for my ability to screen and engage and build rapport and make sure that they're physically safe right here, right now? System level factors, the availability of specialty care, ease of navigating referrals, and access to follow-up care. These can make a huge difference. I had the privilege of meeting with one of our partners in the Midwest. We recently merged and became a conglomerate, across many states instead of just being in the Southeast. A nurse who started a Safe Mom, Safe Baby protocol. And they are so well resourced and they've gotten this down to such a science that they've achieved better perinatal outcomes for these kids where intimate partner violence is involved than the general population. How great is that? So you can do a lot with the right resources. So, drivers of negative experiences, it's about what you would expect. Long wait time, a sense that the physician or APP talking to them is responding to them with condescension or pity, a perceived lack of empathy if they decline to get the police involved, and assumptions about survivors' intelligence, substance use, culpability, or truthfulness, right? So again, especially if you're dealing with somebody who does not fit your personal image of what a victim looks like, or the media generated images, we do tend sometimes to show some skepticism. And not most of us. When I say we, I don't mean everybody, I just mean we have to be mindful, right? And especially in a psychiatric ED, I imagine even in a general ED where you've been doing this for a long time and people tend to get a little bit cynical, right? Oh, this person's just here because they're homeless, that kind of thinking can creep in. You have to be very careful. It's not our job to determine the truth. It's our job to take our patient as we find them and give them as many resources and as good of a chance as we can, okay? So if they feel like there's a lack of respect for their autonomy, right? And you still see this sometimes where people will say, if you're not going to leave or if you're not ready to leave, I can't help you, because they're frustrated and they don't want to face the pain of knowing that their patient is highly likely to go back to the situation. How many tries does it take to leave somebody? Anybody? Okay, you've got 7. All right. 5 to 7. Okay, yep, that's what I have too. And so if you are seeing them during, one of those first 4 or 6 attempts, and you think that it's going to be, wrapped up neatly by the end of your visit, you're sorely mistaken. And if you can get them to come back and see you, if you're in the primary care setting after they've disclosed, you're doing amazing. Lack of privacy, right? Do you feel safe with your partner? And they're sitting as close to you as 2 people at one of these tables. Yeah, it's great. Why? What a question, right? Virtual visits are really great for this, right? We have no idea who's in the room, right? And so a lot of sensitivity to that is important, especially in the modern world where so much is done virtually. And focusing on only the physical aspect of the injury is another driver of negative experiences for patients. Drivers of positive experience, seen promptly. There's not much we can do about that in this day and age. We're all trying to get through the board as quickly as we can, but we can be non-judgmental. We cannot rush, right? Whenever it's possible. I know sometimes we get called out for codes, things like that. Yes, even in the psychiatric ED, there are codes. Seeing them in a private setting and accessing aftercare within a reasonable time. I know that for us, we've got a virtual transitions in care that we can do. The program I mentioned in our Midwest campuses has case managers that are assigned. So anything like that you can do for close follow-up is great, and respecting somebody's autonomy. People know what's going to keep them safest. A lot of times they know whether it's time to go yet or not. They know what the specific risks are. People are subconsciously quite adept at keeping themselves as safe as they can, and we have to trust that. And it's hard sometimes. Drivers of negative experience for clinicians, okay? Lack of time, right? How many of you feel like you've got as much time as you want with every patient you see? No? Yeah. Same. Inadequate training or comfort. How many of you got any training on intimate partner violence? I finally got a little bit late in residency, one lecture by a psychologist. No, anybody else get trained? That's pretty much where the whole field is. Feeling powerless. I get this a lot. I get this feeling a lot when I see kids and the parent discloses to me what's going on in the house. And there's nothing I can, it feels like there's nothing I can do. I've learned some ways to get non-written resources to people, but it feels very hopeless because you're like, oh, you're here because your kid's acting out. Oh, there's frequent yelling in the house and substance use and dad's throwing things or mom's throwing things and threatening that they're never going to see the other parent again. Well, let me write you a prescription, right? Negative assumptions about people who experience IPV. And this can be a defense mechanism too. We really don't like facing things that we can't fix, right? Lack of community resources. The patient refuses legal intervention and we feel frustrated, right? Which is not an invalid feeling, but you know, it still contributes to our own sense of helplessness and burnout. The patient accepts legal intervention, but law enforcement or attorneys are perceived to be non-responsive. And I've had very mixed experiences with law enforcement and with attorneys before. Drivers of positive experiences for clinicians. Access to multidisciplinary team, right? Embedded in the ED, if this study was about emergency room, to assist with IPV care. Resources in the community, feeling adequately trained. Oh, sorry about that. Feeling adequately trained. Specialty care is available within a reasonable time frame. So a lot of the same things that make it better for patients. And support to navigate the vicarious trauma and negative emotions. How many of you have gotten any training on vicarious trauma? No? Yeah, me either. So I solved that by developing one. That was the best I could do. And you really do carry this stuff with you. And we do have these wounds that people can't see. And if we don't have an outlet for that, it's going to show up in our work and in our homes. So there's some conflicting recommendations with universal screening. Okay. I'm going to tell you, and this is a little bit controversial, so this is just my opinion. I'm not speaking on behalf of Advocate Health, all of those things, right? I'm not a big fan of universal screening for very many things, okay? Because I was a probably a second-year medical student. By the 8th time I heard if primary care docs would just take 10 extra seconds to screen for X, we could reduce this by Y. I was like, those poor folks, what else do we want them to screen for, right? And, you know, after all of these 10 to 30 second things that we're being told they should do, when do they get to address the problem that the patient is there for? And how good of a screening is it going to be if you have to screen for 8 things? So I like the case-based indicator a little bit better, okay? But again, this is a personal opinion and not, you know, reflective of my institution. In other words, don't get me fired. So steps to take, separate any potential abusive partner before screening. This feels like a duh, but it can actually be really hard to do. And especially if somebody is Johnny on the spot, I've got to be with you so I can give you the information you need. And really, it can be really hard to separate, and sometimes you can't. And in that case, I don't tend to try to screen. Create a safe, non-judgmental environment. You should listen, validate, and support decisions, right? If somebody's going home, maybe talk about a go bag or what they're going to do or what code word you can have with them if you're going to be following up, right? Now, I twisted my ankle or, you know, something like that. Know the mandated reporting laws in your state. Generally speaking, there are 2, actually probably 3 general guidelines for mandated reporting. Any crime against a child, if the child is directly present during the intimate partner violence or can witness it, and if the victim is a vulnerable adult, So maybe they are, some states define this by age. I think every state recognizes if somebody's got cognitive impairments or severe physical limitations, that they would recognize them as a vulnerable adult. If you're wondering if you should report, most of the time, the right thing to do is report, but you should consult with your legal if you're concerned. Collaborate about documentation. Okay. How many of you work with an EMR where you can mark something sensitive so it doesn't go to the portal, the patient portal? Okay, a few of you, right? And the rest of us have to be we do, right? And I'll often tell people I can mark your notice sensitive. That way they can't see it, but that means you also can't see it in the portal, and they almost always say yes. Please mark it sensitive, okay? Being aware of who has access, right? And remember that geriatric patients and some other patients may be underscreened, so beware of your own biases. Code words, like I said, an emergency plan, referral to specific resources, screening for sequelae, screening for strangling and other high-risk indicators. There is a program called the Danger Assessment online. I've taken it. I think it's maybe $150. It's not very expensive. And you can retake it periodically as many times as you want at no extra cost. Dr. Jacqueline Campbell, who's a DNP, or doctorate of nursing, I don't know if she's an NP, made this. It's through Johns Hopkins. It's fantastic. Some of it's a little dated, but most of it, is very relatable, and it's extremely accessible. It's a very easy training to kind of wrap your brain around. So, treat substance use and other mental health disorders aggressively. This can help both the perpetrator and the victim, okay? If you're treating the perpetrator, and you will, and they won't self-identify, okay, you can be making the whole house safer, okay? Make any mandated reports, educate the patient on the enhanced risk factors that might be present for them, and monitor for destabilizing factors. A very powerful motivator is explaining the impact on their children, I've found, in terms of getting somebody to engage with you on good safety planning. So World Health Organization has this mnemonic, LIVES, as an approach for talking to patients. Listen, inquire, validate, enhance safety, and support. You don't have to agree, but you do have to support if you ever want to see them again. Protect yourself legally, okay? Mandated reporting, we've covered, right? Document but ensure privacy, we've covered. You also don't have to document everything that you think, okay? When you're thinking of documenting, think about whether it's going to help the next doctor take care of the patient, okay? Collaborate with the patient about the level of access the perpetrator might have, like I said, to the records. This is really important because people want to do something, right? We all want to do something and we all want to be on the right side. Do not, please do not render an opinion on parenting or custody. Do not provide a letter. Do not provide a statement to the court. Don't put it in your note. These are incredibly complex and sensitive decisions. And this is an incredibly dangerous territory to get into personally and professionally. A lot of my colleagues who do custody evaluations have a concealed carry for that reason. And physically, okay? If we have time, I'm going to tell a little story about the time that I felt most afraid of a patient. But when these things are involved, you want to make sure that the perpetrator's ire doesn't turn toward you. Google yourself every couple of months, get personal information removed from websites. Most of these familytree.org and other things will quickly remove you because they don't want that kind of hassle. So if you say, get me off of this website and you provide your email, within minutes, you'll be off of there. And these websites have a lot of information, your address, your kids' names, where you've lived before, who you might be associated with. That's usually where the spouse and kids come in. So this is an important, free, easy step. Understand the perpetrators have gone after healthcare professionals in the past. And if they're known, provide their photograph to security. Especially if they're in your hospital or clinic, the patient, and they tell you that somebody's just been served with a restraining order, for example. I will tell you that this is also big for hospital security in general. I'm part of our behavioral threat assessment and management team. We break workplace violence into 4 types. The 4th typology is somebody associated with the employee, typically an intimate partner who's posing a danger to them, brings that danger to work. And we just saw it with a nurse earlier this week who was killed by her partner who followed her to work. Dr. Tamara O'Neill from a few years ago, killed at work. Perpetrator shot her, killed the pharmacist, killed the police officer. So this is a critical piece of operational security as well. Okay, the reason I chose this graphic is because I was invited to attend the Firearm Injury Prevention Summit, hosted by the American College of Surgeons in 2022, I think it was. And the man who gave the keynote address began and ended with the statement, "Communication and cooperation save lives." And I think that's true in so much of what we do. I will quickly tell you why I'm so big on personal security. I treated a man who was somewhat psychotic, but was mainly sociopathic, who had, his wife had just been through it. I mean, and it was a lot of the coercive control, cruelty type of mind games. And he himself, you could tell, had that, kind of complete lack of empathy, very vindictive. When I interviewed his family, they said, yeah, he's still angry with us about things that, happened when he was a teenager. And this person was roughly my age. So he stayed on our unit for a long time because of the psychosis piece, but there was all these other things going on. 5 or 6 years after I treated him, I see somebody shouting out their window at me as I'm going to Whole Foods, yelling, "Hey, we should get coffee sometime." He's smiling, and I'm like, yeah, first time I mistook him for another doctor. I just sort of nodded and smiled and, walked in, followed me into Whole Foods. I recognized him as soon as, I was close enough to see his face. Made a scene, was picking things out of my grocery cart, but was not threatening me, was being loud, jovial, and had the most chilling look of hostility in his eyes that you can imagine. Goes up to, buys one thing from Whole Foods, makes sure he's going through the register at a different lane, same time that I am, and is asking the clerk loudly, "Let me ask you a question. Do you think freedom is a good thing or a bad thing?" This was somebody I'd been to a commitment court with and had, gotten more time on. So I asked Whole Foods, could security walk me out? So they send security. I'm going to step over here so you guys can see. I'm not very short. I'm not very tall. Security was a woman who came up to here on me and was wearing one of those reflective vests. This was great. I didn't go back to that Whole Foods for a while. That's all I'm going to say is shopper beware. But I have no doubt that this person would have not hesitated to do harm if they were in a more isolated area. All right, I'll take questions, case discussions, whatever you have for me.
Thank you.
My pleasure.
Thank you very much. You are delightful.
Oh, thank you.
Really a pleasure to listen.
Thank you.
My question is about hotlines
Mm-hmm.
for women
Mm-hmm.
at various levels.
Yep.
Because we have our local and our regional and our national.
Mm-hmm.
Do you think our national hotlines are adequately funded and staffed for women? What's your experience with that?
I haven't had much experience with that because usually I am the hotline. They present to the ED for some other reason, right? But in general, do I think we're adequately funded and staffed for any of our mental health? No.
Thank you.
Sure.
How often do you have success in interpersonal violence between the partners in getting them both to change and reconstituting a family?
So I usually only get to see one, right? And I never really get to find out because I'm in an emergency setting. So unless they come back, right, And the most common thing that happens for me is that they're there because of their kid. And then they disclose to me.
There any literature data on it? If there are any successful programs?
On programs, yes. When you talk about treating the perpetrator, we're in a much worse position in terms of the data, because it's really hard to get accurate data, right? And a lot of the methods that are sort of mainstream for this, if you can even have a mainstream with such a small population, it's very hard to get good numbers, are not really empirically validated, right? And so the Duluth model, have you guys heard of that? Okay. That was started by a domestic violence intervention program. I can't remember the exact, it said DAIP, but I can't remember the A now. And it is a kind of societally focused program with group therapy, helping perpetrators. And they're very open about the fact that their approach is quite gendered and they're not looking to make it not gendered, right? So it takes the approach with men that they're violent toward women because being societally kind of, I won't say programmed, but influenced to be so. And the data is at best, it's kind of, a slight drop in recidivism, right? Same thing with cognitive behavioral therapy. We're starting to talk more about mentalization-based therapy, being aware of one's own state, mental state, and being able to appreciate the mental state of another person. We'll see. I think also I've seen a lot of diversity in etiology, or at least what I perceive to be diversity in etiology, right? You've got people where if you treat the substance use or you treat some other things, they might get better. And it's, maybe driven by modeling. The man that followed me into the grocery store, I don't think this had ever been modeled for him. I think he was more on that sort of sociopathic type of spectrum. So it really, like I said, I see different things. It was worsened by the psychosis, but I don't think it was ever going to go completely, that was ever going to go completely away.
I don't see any other questions. Oh, now we have questions. There we go. I see one now.
Hi, just a quick question. You mentioned that there's are cases in which an armed perpetrator could be temporarily unarmed. What does that mean exactly, and how is it enforced?
Great question. So 21 states have red flag laws, right? So it's not in every state. But these are states where the police can actually go in and take the guns. And, some of them, have varying lengths, it's there, but it's always an emergency order followed by a court hearing to determine if they're going to grant the full order. And then, it could be a year. It just really depends. The judge can put other things into it, like that the person has to have received a mental health evaluation, or they have to have shown that they have been consistent with their treatment. Again, it's very state dependent. We don't have it in North Carolina either, by the way.
Can you mention the name of that training program from Johns Hopkins again? And do you think that's an appropriate tool to provide extra education for learners?
Yes, I think it is absolutely appropriate, and it is called the danger assessment, which is great. And it's been adapted to different populations, although they still have work to do on that.
Thank you. I think people can tell we're getting close to lunch.
Yeah, it's always hard to be in the pre-lunch spot. I really appreciate you guys sticking with me.
Yep. So we will break till 11:45. Please go get lunch because we have a lunch speaker beginning at 11:45. So thanks for your attention this morning. We'll see you soon.
I was looking to see if I had my cheat notes, but I don't, so I'm gonna have to try to remember. My, I don't want to, you could, come on.
Gather the crew.
I'm good. I want to see how much I have. I have my notes. Yeah, I'd say like 90% of the time, if there's no first interview, and usually I have a lot of my notes in there, and it's not unique. Okay, I do have it if I want it. I might just, I don't know. I like having it in my notes. I could also just go bring it. Is it easy for you to see or no? Where's your office?
Right?
Like in the hall?
Yeah.
Okay. So far.
Good.
How many jobs do you have? Because I get a lot of calls from you on everything.
I'm like a hodgepodge person.
Yeah, you do everything. Well, how are you doing?
Good.
How you doing? You're good? That's great. Sending it through. That's on Monday. I'm picking up with them. Okay. She did better than that. So. Yeah. She's really grateful.
And now it's great people born, really. Even older, my dad was even older.
Melissa.
Yeah, I already just did it.
Yeah. 62 weeks.
Yeah. I mean, you can go forever, right? That's it. Yeah. Right. Your dad would probably know. One of our dogs was that age.
Yeah. Yeah.
So who's here now?
Yeah. It all sort of private. Yeah. Me too. I'd love for them to come. Yeah.
Yeah, I went right before you. Just went over. Yes. So they have.
So I had bacon this morning. Yeah. Are we trying to justify our food? We just kind of the same choice. Yes.
Thank you. I saw you. No, I got it. Yeah. That's good. Good. No, let's stay up here. Ryan, don't be offended.